All right, so I'm recording. It is, 8:30-ish on 2/2/22/21. Thought about this the other day, and I don't know if I ever mentioned this to you guys, but are any of you concerned with the fact that this year is called 2021? Thought about that. Think about that a lot. Just saying. Anyway, so we're going to talk about pain and chronic pain and neuroscience and everything like that. Out of all the patients you're going to encounter in the clinical world, chronic pain patients or patients that suffer from repetitive stress injuries, stuff like that, are probably the most challenging patients that you can deal with. Because what do you think one of the biggest things that they think about their pain is? It will never what? It's never going to go away, right? It's this cycle of hopelessness, right? That they get stuck in, that it's just never going to go away. It's always going to be what it's going to be, right? And we fit into that in the medical field, right? I've mentioned before, we talked about painkiller with prescriptions and painkillers, that we've actually conditioned America to think that they should exist without pain. And that's just not life, right? I mean, we're all going to have aches and bumps and soreness. And I've got a huge black and blue mark on my ankle that I have no idea how it happened. I just realized that after you go over the 40 hump, random bruises start showing up in your body. It's just the way it is. Some of you may say after I hit the 20 bump, that's where random bruises started showing up on my body. Just happens, right? You're gonna have pain. Every morning I get up, it takes me 2 to 5 minutes to kind of get my back in line, stretch my shoulders out, right? Get myself to where I'm like, okay, I don't hate life, and I'm gonna get up and get out of bed, because we're just decaying as the time goes on. There's just no other way about it, right? But if you watch television in any type, right? At least here's the good news, at least pain, the opiate pain medications can't advertise on television. I can only imagine if that was legal. That would be just bad. But I mean, every day when you're watching television, you've got ads for Advil, for Tylenol, for Advil with Tylenol, for, for Aleve, talking about how to live a pain-free life. But in reality, that's not logistically right. All of you, I'm pretty sure right now, if I ask all of you, you can find some part on your body that hurts, right? If you're like, okay, I got to think about, yeah, you know what? My low back hurts a little bit, right? That's going to be most of us, right? Most of us are going to say, yeah, my low back's a little achy, right? That's why I've got this nice lumbar support in my chair. That's why I occasionally put heat on my low back, right? Or maybe some of you, yeah, my shoulders are sore, some of you might have repetitive strain injuries from your hands, from playing games, knees, exactly, right? And you especially notice them when you move, right? All that chronic pain, if you're sitting there, sometimes you can kind of ignore it. And then you get up and move and you're like, oh, okay, this sucks. This is not fun. And then you get moving and you kind of forget about it again, right? But this takes it a whole step further when these patients get stuck in this cycle. So what do patients really want to know when they come into therapy, right? The number one question patients ask most doctors is, what's wrong with me? That's really what they're saying, right? When they come into physical therapy and they get evaluated by a PT, they want to know what's wrong, right? Why am I in this pain? What's causing this pain? They want to know how long it's going to take to treat me. And chronic pain patients, what could be the answer to how long it's going to take to treat me? The one phrase that they don't want to hear, I don't know, right? I don't know how long it's going to take. What can the patient do to make it better? Some patients want that, but really the other thing they want to know is, what are you going to do to make my pain better? Does my insurance cover this? Why are they concerned about insurance? Why do you think most patients are concerned about insurance? Because insurance is going to cover most of the cost, right? Have you guys had your insurance lecture in 204 yet? Is that coming up? Have you had it? If you haven't had it, then it's coming up. So there'll be a lesson. I think so. Okay. Will I miss any family obligations or work? Which do you think weighs heavier there on patients? Do you think missing work or missing family obligations is more important to them? Okay, so I got a bunch of people. Now, think about that for just a second. Okay, Kelly says family. Good. Okay, well, at least we got 1 of 3. But think about that for just a second, because I would be willing to bet if you ask most patients, work is the most important, which is a uniquely American trait. It is very uniquely American. Because most of you, if you go outside the United States and if you go outside the United States and ask that same question, most other countries, and I've worked in Denmark, I worked in Sweden, most other countries are going to say family obligations are more important, to the point that companies give you time off to spend time with family. Novel concept, right? But here in America, we're so used to being the working poor. Yeah, but we're so used to being the working poor here, right? I mean, the big joke, because I taught in a what do you call it, a career services class way back when, and I always joked about the fact that we always call it a job, right? JOB. Does anyone know what job stands for? Just over broke, right? When you have a job, you're just over being broke, right? Most Americans right now can't survive a $500 shortfall. That's kind of scary when you think about that, right? And then how much will this total cost? I mean, that's the ultimate thing. If you tell a patient, well, I can fix this, but it's going to be $500, and they don't have that $500, it's a non sequitur, no starter, right? They can't do anything. So they really want to know this. But out of all the things, when I'm dealing with the chronic pain patients, I have to say this up here, what's wrong with me? Right? That is one of the number one questions they want to know. And they want to know this because they don't understand what's going on in their body. I mean, you break an ankle, it's easy to understand what's going on there, right? But if you have chronic pain, it's not so easy to understand. So let's look at a patient with low back pain with radiculopathy. All right, so we've got a patient with low back pain and radiating pain. What does this patient look like? What are some things this patient is going to complain about? So lumbago with radiculopathy, what are they going to complain about? Obviously, pain in the lower legs, right? Good. What's that pain going to feel like? How are they going to describe it? Burning, tingling, stinging, right? It feels like bees crawling on my legs. What about their low back? What's that going to feel like to them? Sore all the time, or maybe not at all, right? Could be sore and achy all the time, but could also equally be not at all, right? At that point, the body has shut off those nerve endings because you've ignored them for so long. That's why you're getting the burning, tingling, numbness down the legs, right? So structurally, what's probably wrong with this patient? I know I'm stepping into the realm of diagnosis here, but let's pretend for a little bit. Since so many sciatic patients, exactly, right? What's structurally probably wrong with this patient? Because we can go from a scientific standpoint, know what's structurally wrong. What usually causes it? Could be tight hip flexors, injuries to the low back, good, right? What's maybe structurally wrong at the spine? Spinal disc problems, right? Maybe a shifted disc. Could also have that fun term, the spinal stenosis, right? Where the spine is actually blocking off some of the nerve. In the average physical therapy clinic, how long does it take to treat this patient? What's the normal treatment plan? Okay, 3 months. Pretty, yeah. I mean, I would say anywhere from 6 to 8 to 8 to 12 weeks, right? Somewhere in that range. So you're looking at the patient and you have to tell them what's the one thing they can do to make their pain better. What's the one thing they could do that would make their pain better? Move. Yeah, right? Exactly. Move and stretch. The best thing for you to do is move. And what's the patient going to say? Every time I move, it hurts. And you have to convince them that's normal because television tells them it's not. Right? So let's say, so what are we going to do to make them better? What kind of stuff can we do? We've got a whole bevy of stuff, right? Give me some things that you might do to this patient to make him better. Posture, good. Soft tissue, yeah, right? Moist hot packs, yeah, put me on that hot pack. It feels so good, right? What other stuff? Put on your therapy caps here. What kind of stuff? What program might we put them through? What type of low back protocol? McKenzie probably, because most of us have an extension problem, right? Even though I know Dr. Reskin says McKenzie is not just extension, she's exactly right. But a good chunk of the patients that come in are extension problems, right? That we're hunched over too much. Out of all of that, so we've talked about posture, and moist hot pack, McKenzie, which deals with doing the exercises. We could throw e-stim and ultrasound in there, right? Out of all those we just talked about, what do you think is going to be the most impactful for the patient as far as making them feel like they're valued as a client? So posture, moist hot pack, soft tissue, McKenzie, e-stim, ultrasound. When asked for most patients, what do you think the one thing they say that makes them feel, yeah, soft tissue? So Kenda's right, exactly, right? Why would soft tissue make them feel like they're valued? What are you doing at that point? Human touch. Yeah, you're spending one-on-one, right? You can't do soft tissue on the low back unless you're one-on-one with them, right? It's not like you can have your hands on two different patients at the same time. Well, I mean, theoretically, you could, and some clinics probably try that, but you're spending time on it with them, right? And that makes them feel valued as a patient. What's the number one things we're cutting out of our physical therapy treatment? Soft tissue. Yeah, right. Soft tissue and just manual therapy in general, right? I'm going to add, stretching, all of that into that manual therapy bucket. We're cutting it out because it's time consuming. But we also know that it results in better customer service surveys. Just putting it out there, not saying anything or making any judgments there. Okay, so does my insurance cover this? Most insurances cover low back issues. Why do you think most insurances will cover this without too much question? Yeah, it's common. Good. Right? It's the most common injury that we're going to see in physical therapy. The other thing is, it's cheaper to send somebody to physical therapy than to send them to surgery. Right? In the long run, it's cheaper to send them physical therapy than it is surgery. So we're going to do it. So let's just say that our program is 8 weeks. We are a really fantastic clinic. We are going to be the awesomest clinic of physical therapy. And we get most of our low back patients treated 8 weeks, coming 3 times a week. So 24 treatments, right? 3 times 8 equals 24, just in case you forgot the math there. Out of pocket, right? What's the average out of pocket copay for patients nowadays? Okay, 30s, yeah. I may even say it's up to 35 now, but I'm not quite sure. So let's just go with 30 because it's a nice, easy number, right? So 30. So what's that mean that patient's going to pay over that whole 8-week period? 30 times 24. $720. That hurts some families. Yeah, right. So you're talking 8 weeks. So, 3 times a week, you're talking $120 a week. That may be the difference between getting food and not getting food. Just something to think about, right? I mean, I know that in physical therapy, it's always the best idea to do pro bono cases, but man, we're looking at this going, that's a lot of money to a lot of people. That's a lot of money to some of you guys right now. I'm not saying it's not, right? I hate to say it, it's a lot of money for me. I don't want to spend $720 that I don't need to spend unless it's on computer parts. And then I really need to spend it because it's computer parts. Will they miss any family obligations work? Well, maybe, right? We don't know. Can't promise anything at this point. We got to find out how you're doing. We already said how much does it cost. Okay. Thinking about this whole thing, did you give your patient a name? Why? Interesting thought. Okay, good. There's a good answer for it, right? We just went through a whole spiel about a patient and thought about all this, but we never thought about their name. That kind of, I don't know, just presenting it, not with any judgment, just going, huh, right? We didn't say, oh, Sam's got low back pain, right? This is the way we treat most patients, isn't it? We don't treat them like Sukana, or we don't treat them like Kelly. We treat them like, oh God, the 5th low back patient of the day, right? Or the God, not the 4th, not another shoulder, right? You just it kind of gets on you after a while. They stop becoming Sam, Julie, James, and start becoming my 3 o'clock, my 2 o'clock, my 1 o'clock. Just out there, right? We kind of dehumanize ourselves. So let's look at a patient. This patient's had 3+ years of chronic lumbalgia. So 3 years of chronic low back pain. Has a fibromyalgia diagnosis. Has seen 12 healthcare providers in the last 2 years. Pain continues to spread, comes and goes. Has insomnia. Has less than 20 minutes of sitting tolerance, 60 minutes of seated tolerance. What do you think this pain chart? So, let's draw the little person here, right? That beautiful pain chart where you have to put X's on the patient. What do you think their pain chart looks like? Yeah. Forget it. I'm just going to do that. Right? I'll do that and I'll put a minus for the numbness just so I'm lucky. Their pain chart's going to be all over the place, right? And this patient does enjoy doing yoga and enjoy doing Pilates. Low back pain going to stop that? Yeah. All right. When you see this diagnosis, what does your patient, what kind of patient appears in your mind? What does this patient look like? Do you visualize the patient? Okay, woman, okay. What came to your mind that women or woman? Just curious. This is not judgment. This is just what brought you to mind that it's a woman. Pilates and yoga. Okay, good. Not saying that guys can't do Pilates or yoga, right? I'm also going to go along the lines of fibromyalgia, right? Because fibromyalgia is traditionally more diagnosed in women than it is men, traditionally, right? I see this, like I can look at this and I've got this probably mid-40s woman, right? Whose hair is graying way beyond her age, right? She's mid-40s, but her hair looks closer to her being in her 60s, right? She's got bags under her eyes. I can visualize this patient. She walks in, she's kind of forward rolled shoulders, kind of kyphotic back posture, maybe even a little bit of a scoliotic twist of the spine. Probably wearing something like Crocs or cheapy like canvas shoes. Comes in wearing appropriate gear for physical therapy, right? Comes in maybe wearing, loose sweats and a t-shirt or something that she's at least compliant that way. She's not coming in like a pencil skirt or, tight jeans, right? Her eyes just look kind of dead to the world, right? Her face is just kind of almost skin sag. Do you get a similar picture? At least I can literally visualize this patient, because the pain is just making her older than she actually is, right? It's aging you. It just makes you feel much older. So from a pain neuroscience standpoint, we need to change the way some of these questions are worded, right? What's wrong with me is not the best answer here, or the best question. The better question is, why do I hurt? And how long will it take to treat me? Not a good idea. How long will it get better? Will it ever get better? And is there any hope? Is really what they're asking, right? They want you to give them that sliver of hope. And whether this is chronic pain patients or whether you're dealing with a cancer patient especially, they want that little sliver of hope, right? A doc tells you that you've got cancer and you've got a 10% chance to live over 6 months. That 10% is sometimes enough to get you through, right? They're looking for some hope. And then really, we've got to look at, is it going to be more important what we do to make them better or what they do to make them better? What do you think? What they do? Yeah, right? Because we can do all the hard work in the world. If they don't change their habits, there's where they're going to go right back. It's going to be this vicious cycle. So what kind of trepanations could we do? Well, we could do spinal mobilizations, right? We're going back to this lumbago patient. So we can do spinal mobilizations, right? Now, obviously, we're not doing grade 5s, but we could do spinal mobilizations to these patients, meaning PT-wise. Lumbar traction going to work? Could it? Yeah, maybe, right? If it's a stenosis problem, right? If it's a disc that's shifted a little bit, but what if it's something like spondylolisthesis or something like that? Maybe not. Spinal stabilization programs, pretty much what we're going to do, right? And directional bias training, and then modalities. That's what we do all the time. I mean, I can literally see this patient and see a flow sheet, right? I can see a flow sheet, moist hot pack plus IFC at the beginning for 10 minutes, right? And then the IFC set to chronic pain settings. And then we're going to go down and we're going to start with some light stretching, right? So maybe some lower trunk rotations, single knee to chest, double knee to chest. And then we're going to move from there. We're going to move into maybe some crunches to kind of tighten up the patient's core. Can you see the flow sheet going down just like that? Or are you not quite at that point yet? Like, I've seen enough chronic low back patients that I can see this flow sheet right in my head. Like, it doesn't even, it's just boom, there it is. And then ice at the very end. I put them on for ice for 10 minutes. Why? We just made their back better and now we're going to tighten it up. I don't know. Anyway. But yeah, we can do that, right? But what about digging with your patient? Just spending a little time, instead of doing physical therapy, doing a little bit more social or psychosocial therapy. What's your patient probably know about their condition? What do you think they know? Do you think they know anything? Do you think they understand anything the doctor told them? It hurts. That's it. Right? Maybe the doc did MRI and X-ray of the low back and said, you've got spinal stenosis. Like, oh, okay, my spine's breaking. You know what it means, right? Then the question becomes, does your patient even want to know about their back pain? Maybe not. So let's talk about, can we educate them? Sure, we can educate them. But the bigger question is, how afraid do you think some patients are of finding out what's causing their pain? Do you think patients get afraid of that? Yeah. Why would we get afraid of finding out what's causing it? What are some reasons, do you think? This is a fun topic to discuss, so there's not a wrong answer here. They're expecting the worst. They're catastrophizing, right? See the bad things about it, right? The other thing is, think about it. They may have to have surgery. Yeah, right? These are all those thoughts that are going through their head right now. If they find out what's really wrong with them, or the big one they'll find out, ignorance is bliss. Good, right? The other thing I find that they're afraid of is they'll find out that they're the ones causing it. Right? Because, I can't tell you how many patients I've seen that have had lung cancer diagnosis or throat cancer diagnosis that are to this day still in just denial that smoking has caused it. Why would they be in denial of smoking causing it? We have empiric evidence that smoking causes it, right? But if they admit smoking caused their cancer, what did they admit? They gave themselves cancer. Yeah. Right? It's much rather be the factory they worked in, or, that one time that they were in an airplane, or, something weird over just, yeah, I did it to myself. How do you think we're ever, as therapists, scared of learning the real reason they have back pain? Why do you think we might be afraid? It's a good question. We got to break it to them. Good. Yeah, it's hard. Yep. Could it also mean that we can't fix it? Yeah. I think that sometimes worries us because we're looking, again, bottom line. And if it comes down to it, that physical therapy is not going to do anything for them, that they definitely need surgery. I don't know. I think it's some of us worried. Right now, just as you're sitting right now as student PTAs, and you're getting ready to go on your final clinical before you become graduates and before you become graduates of physical therapist assistants programs, right? How confident would you be treating this patient on a scale of 0 to 10? Where would you rate yourself? Not knowing the plan of care, not really knowing the diagnosis, how confident would you feel just walking in and seeing this patient? Kelly says 8. Okay, good. 10. Okay, so we got some high numbers. I would say that if you've been to outpatient, your numbers are probably high. What about, let's just say, for example, myself, when I graduated, I spent a lot of my time in inpatient right after school. Like primarily my first 2 years were strictly inpatient. Okay, so Justin says 5, right? Eric says 60% of her patients were low back. Exactly. So that builds a little confidence, right? Now, coming from me, I graduate out of school, go right into inpatient, work there for 2 years. And then they asked me to go PRN over at one of the outpatient clinics. And this is my first patient. Where do you think confidence would be then? Would it be lower? You've worked inpatient. Yeah, right? Because we don't see this patient on inpatient. I mean, we see them after surgery. We don't see them like this. Ugh. I'll start freaking out, right? What happens if you go in like that? What happens if I go in and I'm kind of hemming and hawing and, well, maybe, and what happens to patient confidence? Down, right? It goes dry. And it's just one of those, you're like, okay. And once you lose that patient confidence, it's really hard to regain it, especially as a student, right? Some of you probably encountered that. Did any of you encounter a patient that heard you were a student and suddenly was like, right? Or you had to convince them you had the skills, right? Maybe to transfer them out of bed. You're a student, you're going to drop me. No, I'm not. If I drop you, I fail. I always laughed when I heard patients say that with my students, because I'm like, man, they've got more riding on not dropping you than I do. Right? But yeah, drops. So yeah, right. Yeah, there's a good. Justin said he had CI wait outside the room because they would address him rather than me. Exactly, that happens. Right. A lot of times when I was going in with my student, I would tell the patient, I'm just here to organize the room. They're doing the treatment. I'm not here. And that's exactly what I do. I'd move around the stuff. I'd wait for them to tell me, can you move the table over here? Can you set the chair up here? And I would become a tech, because I want them to show that they have the confidence to do this, right? So what kind of techniques have you guys used to make you seem more confident than you actually are? Have you thought about that? There. Yeah, right. There's a joke that I've had a lot of experience with back pain. Exactly, right? Some of us can really, when I had spinal cord injury patients, I'd be like, hello, I know what you're going through. A seasoned student. Sounds like you're like tater tots. I like that, right? I used to do this thing that when I was going in, she was like tater tots, or she is a seasoned student. Okay. When I was going in the room, I'd have this thing where before I step foot in the room, I'd read the chart. I know what I'm going into. I'd step away from the door where the patient can't see me, and I'd take a deep breath. Even if I was absolutely terrified of working with this patient, I'd take a deep breath, I'd refocus myself, and I'd go in. I credit a lot of that to, again, my background in the martial arts, because there were plenty of times in the martial arts where I had no freaking clue what I was doing. But I didn't want to do push-ups, so I made sure that I looked like I knew what I was doing. Right? So you have to kind of put yourself in that mindset. Just go in and talk to them. They're human, honest. I've yet to run into like the alien from Resident Alien. And when I do, I'll be like, take me to your leader. So what can we change about the patient's view on pain, right? Can we change the cognition of their pain, their awareness of it? Yeah. Right? Okay, ask them when they have pain. Well, all the time. When's it worse? Well, it's always worse. Okay. Let's try to figure out when it actually truly gets worse. What can we have them keep? I do this a lot with them. Yeah, a dairy, exactly. Get those cows. A journal, yeah, right? I always ask them, can you keep a pain journal for me for a little bit? Just 2 weeks. Keep a pain journal for me, right? Sometimes with some patients, it may be a food journal, right? Because we want to see if they're eating foods that are maybe kicking up their inflammation, but just a journal, right? What I want you to do is when you start feeling pain and you're having a ton of pain, I want you to mark that down. I want you to mark down where the pain's at. I want you to mark down the level of the pain, what it feels like, right? Have them keep a journal on it. Because sometimes just doing that can show them the pain isn't as common as they think it is. Right? And they may find, oh, you know what? Every time that I bend over to pick something up, my pain gets worse. That's correct. That's a little cookie, right? Those little cookies that we like to follow. We can change the beliefs of the patient. We really can, right? Convince them that, it's normal to be in pain. Allay the fears, right? That's kind of, and this is getting beyond. So this is getting a little bit beyond your normal scope of physical therapy, because now we're kind of getting a little bit into psychosocial therapy here, right? Which is one of my backgrounds, and dealing with a little bit of talk therapy. But I would challenge you guys to think that we do talk therapy every day with patients. We just don't know it. I would challenge that Kelly probably does talk therapy and Emily does talk therapy with her kids every day. You just don't realize you do. Sometimes it's talk at, but at least it's talk, right? Same thing with our patients, right? And I'll ask the mothers, and maybe even if there's any fathers here. I don't remember who all has kids, so please don't. I just know that Kelly and Emily had their kids run around the room once or twice, so I know they have kids. Do you get better results by talking to or talking at them? Yeah, to, right? Taking a moment, stopping, going, okay, this isn't working. What's going on? What's going on in your mind, right? I saw a great video the other day when I was watching a conference on pediatric psychology, and the lady was talking about teaching kids that are very, 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 not colicky is not the term, because colicky is a baby, right? But those kids that are really, really hyper emotional, that gets upset because of the silliest things, right? They want a cookie, so they just absolutely, when they can't get a cookie, they go absolutely ballistic. Strong-willed is a good term for it, right? And teaching a way to talk to the child through that, rather than, some parents just see that and, I remember my dad, because my brother was kind of that way a little bit. And usually if the tears started flowing, the belt came out, and then that just caused more tears, right? But the theory was, okay, hold on, let's take 5 deep breaths. Work the child through taking 5 deep breaths. Now, tell me what's going on. Why are you so upset? Okay, well, you want a cookie. Well, why, right? And talking them through it sometimes can be really useful to a kid, because what are you teaching the kid at that point? I do this a couple times. Yeah, I'm almost like parents do this quite a bit, right? But oftentimes, does it get skipped or just ignored, right? I'm not saying that parents are bad, but let's face it, parents got a lot on their plate. Yeah, teach them how to manage their emotions and express them. If you don't teach it, then the kid's going to go to work when they're 18 years old, and they're not going to get a cookie, and they're going to go into their boss's office and be like, well, I didn't get a cookie. How did you dare not give me a cookie? And they're going to get fired, right? Teaches them how to, and also what emotions are appropriate to get out of control about, and what maybe aren't, right? Is a cookie the end of the world? No. But to a kid, a cookie is the end of the world. I mean, to some of us, a cookie is the end of the world, especially if it's like one of those warm Mrs. Fields cookies. That could be the end of the world if we don't get it. Or Cinnabon. Sorry, I don't know where that came from. But working with these patients, all of this should be modified before we work on physical therapy. Because if we don't modify this before physical therapy, it's hard to modify it during. Again, like Kelly said here, how to manage our emotions and express them. Well, in reality, that's what we're doing with patients here, right? How to manage what they're experiencing and how to express when it's good and a bit worse. So it's clearly been demonstrated at this point that cognition and pain are not just related, but they're intertwined with another. I don't know why I have a question mark there. I gotta take those questions out. And that we know fear of their condition can make it worse. Fear of the unknown is one of the greatest fears everyone has, right? I could ask you right now, how many of you guys are afraid of the boards right now? I know a lot of you were when I gave you that book. Why are you afraid of it? It's a test. Other than the fact that it's your life and blah, 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 right? But in reality, what you're saying is, I'm afraid of not knowing, right? I'm afraid of the unknown. I'm afraid of what that test might look like. If I could know that my test was on these 50 questions, I'd feel better, right? If I could say, here are your 50 questions, study them, would that make you feel better about your test? Sure. Because it's no longer an unknown. And that's what's really the test you're scared of, is the unknown. It's not necessarily the test. And it may be failing, yeah, but it's failing because you didn't know the answers, or failing because you picked the wrong answers, right? So now we get a fear of the unknown. We get a fear of their condition. Does that then catastrophize the situation? Does that make it worse? What about, let's take it to the boards again. Getting afraid of the boards, could that make the chance of failing the boards higher? Yeah. Right? So that catastrophizes it. It makes it a little worse. Same with the patient, right? So in reality, when you're looking at chronic pain patients, you're just looking at you guys taking the boards. I mean, there's direct correlations to be drawn here. Now, correlation does not equal causation. We've talked about that in research, but there are some really direct correlations here, right? What about the patient's social circle? Could social circles, social circles, I can speak today. Could they make them better or worse? Yeah, both, right? Depends on what social circle you're in, right? Let's say that we talked about this and I said, I had this vision of this patient and they're mid, 40s, and they get together with a bunch of other, mid 40s people that all have low back pain, and they're all sitting there and they're all talking about their low back pain. What probably happens to all their low back pain while they're sitting there talking about it? Hurts. Yeah, they get more cognitively aware of it. What if you have one of those friends that never has any pain, right? Those bubbling, smiling, life is beautiful, and they always tweet that, they put on their Facebook pages, live life, love, and they're always that shining, bubbling, smiley person. Does that sometimes affect your mood? Why are they not in pain? How are they doing this? Right? I want to punch them. How about the internet? Can the internet affect their pain? Oh, yeah. Right? What's some of the famous phrases we hear in physical therapy? One of the ones I hate the worst. So I was looking on WebMD. Right? I was looking on WebMD, and it says that I might have this neoblastoma. What? You have a torn ligament in your knee. Oh, well, it said it could have been a neoblastoma. No. You have torn ligament in your knee. Right? And then clinicians. Let's say they go to physical therapy before they come to your clinic, and that physical therapy does no manual therapy to them. Just straight, and there used to be a clinic in town that did this, that only did modalities with patients. That's it. No exercise program, nothing. It was just straight modalities. They came in, they went on hot pack for a while, they got some ultrasound, they got e-stim, they got nice pack, and they went home. Maybe some traction. Eric is like, that's insane, right? Because we know that all of those are adjunct to the physical therapy, right? We know this. They're not going to get any better. They're just going to get addicted to the modalities. We know this now. We're cognitively aware of this. But now they come to your clinic, right? And I don't know if any of you I experienced this quite a bit. They come to your clinic and they're expecting you to just put them on hot pack, cold pack, and you ask them to start doing some exercises. And they're looking at you like you're a three-headed alien from Jupiter. Exercises. Well, the last clinic, did anyone ever hear that when they're working with the patient? Well, the last clinic, there's another phrase I love. Well, the last clinic did this with me. Well, the last clinic did, right? It's really hard for me not to say, then why aren't you at that last clinic? Right? It's really tough. Like sometimes there are those, you're like, I bite my tongue. Because you want to sometimes, right? Come on, all of us admit we've had those patients where we want to say what we are thinking, but we have a frontal lobe, right? And that frontal lobe filters it, hopefully. Now, maybe you have a traumatic brain injury and the frontal lobe doesn't filter it as well, like me. But yeah, right? Well, let's say these patients are seeing the ever-present Las Vegas pain clinics. Why do patients have to visit pain clinics? Okay, to get pain meds. To get pain meds over a short stint, right? Most doctors now, if you go to the ER, only get prescribed maybe 10 pills to you. Hopefully. That doesn't mean it always happens. Sometimes they prescribe like 50 anyway. But yeah, so you're going to get a short dose of those pain meds. And if you need longer doses, you have to see a pain clinic. Does that just not make them the gatekeepers to pain meds? I mean, really, does anyone else see that? Like it literally make what? This is not a judgment on any pain clinic in town, and this is not making fun of any pain clinic in town. But what is the difference if that's what their job is to disperse pain meds, them than the corner drug dealer? What's the difference? Legal, that's it. Okay. But do you see a parallel there, though? At least I'm hoping some of you see a little bit of a parallel, that I'm not totally crazy in thinking this. Right? In reality, they're just the gatekeepers. Now, are there some really good pain doctors in town? Absolutely. There are a couple of them that I love hearing that the patients are going to them, because they're treating not only the pain symptoms, but also holistically their kind of mind, body, and spirit as well. And then there are some that just literally the patient comes in, they pay their copay, they get their scripts, they go home. Right. So Eric says you went to one after a car crash and they gave you shots, right? It could, but here's the question. Did you 100% know you needed those shots? Just curious. Right? Could you have just gone to PT and gotten better the same way? Yeah, right. Okay. I'm not judging you on this. Please don't think that, but I'm just saying, you see where I'm going with this, right? It's just one of those of, was it the shots? Did the shots help? Probably, absolutely. Right? Probably, absolutely. That doesn't sound right. Probably did help, right? Probably kicked down. They probably gave you cortisone shots, and it probably kicked down some of that inflammation back there. So yeah, but was it worth the risk of injection? I don't know. Anyway, but you can see where I'm going. Some of you don't. Some of you are like, where is Mr. McKeever going? I feel like he is a squirrel chasing a nut right now. Bear with me. So let's look at fear, right? We have whole TV shows based on this, don't we? Fear? Fear Factory, did you ever see that show? Yeah, right? Where they put people in like plastic boxes filled with tarantulas. I think that would probably be my biggest fear ever. I don't like things that are 8 legs. 8 legs die. I don't know why. I don't like bugs either, but that's beside the point. I think cockroaches are by far my least favorite animal in the world. But Fear Factor, right? AJ's finally awake. He's like, Fear Factory. No, just kidding. Look at all the ghost shows that are on now. I bet I could go out right now, turn the TV on, and Discovery, Travel, or there's another one. I can't remember what the third one is. I bet there's a ghost show on one of them. Like Paranormal History. It may be History, good, right? Paranormal, Caught on Camera, Ghost Hunters, Ghost this, Ghost that, Ghost Adventures. Why? Fear of the unknown. Right? It sells. Fear does sell a little bit, right? So Merriam-Webster definition of fear is an unpleasant, often strong emotion caused by anticipation or awareness of danger. Did anyone see the plane story from this weekend? Over Denver? Did no one see it? Am I the only one that saw it? Okay, Dylan says he saw it. Yeah, the Boeing, right? Where the engine literally caught fire mid-flight over Denver. There's actually a photo that one of the people in Denver took that they were on the plane and then they got home, and guess what was in their yard? The front of the engine. The ring that goes around, you know that ring that you see around the front of the engine? That ring was laying in their yard, buried about 2 feet deep. Well, luckily it was in the yard, not in their house, right? But think about that for a second. So let's approach it from 2 different perspectives. You're in the plane, you chose the wing seat. Why does everyone pick the wing seat? Why does everyone want that wing seat? Oh, what's it give you? Extra space, right? Because it gives you a little bit extra but what's the side effect of picking the wing seat? Then you're usually part of that. You have to sit there and they're like, okay, here is your safety control manual. In your safety control manual, you see you are seated right by one of the exit wings or the wing exits. It's your responsibility to help patients in the event of an emergency, right? Do you remember that speech when you get on a plane? Now, you're sitting on that plane and you're just kind of zoning out. Maybe you're watching a little bit of Teletubbies. I don't know what you're doing on the plane. Maybe watching a little bit of Ghost Adventures from Zach Baggins here in town. And you look out the window and you just happen to glance out and you see the ring on the front of that engine fall off and the engine catch fire. My initial first impression is I'm making sure I'm not staring at my screen to make sure that I'm not like somehow confusing what's going on my television for what's out there. So we're all going to die, right? Every man for himself, right? What is going on? What are you going through right now in your body? What does that put you into? Fight or flight, right? Good. Now, interesting, they interviewed the pilots. The pilots just literally, matter of fact, they're like, oh yeah, we trained for this. It's a normal occurrence. Sometimes engines fail. We just re-rotated the plane around, taxied back down to Denver, and landed without any problems. Just completely deadpan. Let's compare their response to probably what's going on even in the flight attendants. Because let's face it, even the flight attendants at this point are a little bit like, okay, we gonna die. Right? You see that flame out there on the wing because you're thinking the next thing is the wing's gonna go. Right? And if the wing goes, plane doesn't fly. You kind of need the wing for flight. Pilot's just like, yep, it happens all the time. Not a big deal. We train for it. Turn around, land, right? Sully, right? Does everyone know who Sully is? Other than Sully Erna from Godsmack, but the real man Sully, right? What was he? Yeah, the Tom Hanks movie. What he landed a plane in the middle of the Hudson, like it was nothing, right? Like it was not in the movie. If you get a chance to watch it, it's actually kind of interesting because it tells a lot about the story. But just landed a plane like it was nothing in the middle of the Hudson. Think about that. Those patients, or not the patients, those people inside that plane, probably losing their gosh darn minds. Terrified. So let me ask you a question. You're on that plane. You're over Denver. Plane catches on fire. Do you have any pain in your body at that point? Okay, so Kelly says no. Why? Okay, the adrenaline was one thought process. The other thought process is the body is saying at that point, pain is irrelevant. Isn't it? Because here's the deal. It doesn't matter if I'm in pain. If I don't get out of this situation, I'm going to die. Fair assessment? Right? It's just kind of interesting. So if you look at Dr. Google says pain is an unpleasant emotion caused by the belief that someone or something is dangerous, likely to cause pain, or is a threat. Huh. So does that mean that pain could be caused by domestic violence without the domestic violence even happening? Yeah. Or even child abuse, right? Does that mean that a child that just gets yelled at all their life could be in pain? Sure does. So Wikipedia says, an emotion induced by perceived danger or threat, which causes physiological changes and ultimately behavioral changes, such as fleeing, hiding, freezing from perceived traumatic events. Fear in human beings may occur in response to certain stimulus occurring present or anticipation of the expectation of a future threat perceived to as a risk to oneself. The fear response arises from the perception of danger, leading to the confrontation with or escape from or avoiding the threat, also known as the fight or flight response, which we just talked about. Which in extreme cases of fear, horror, and terror can be a freeze response or paralysis. All right, so you guys are sitting here in my class right now. And all of a sudden, literally, Freddy Krueger is standing behind you. And I'm not talking like Freddy Krueger, the actor, so that you can shake, his hand and be like, oh, you're one of my favorite horror actors. But literally, Freddy Krueger is behind you. Or Jason from the Friday the 13th movies, or one of the aliens from the Alien movie. How many of you freeze? Anyone willing to admit you might? I think I probably would for a while, because I'd be like, this can't be real. I'm gonna be looking at my coffee going, all right, who put what in my coffee? Right? But you can end up frozen. Wikipedia does have an interesting addition that the other two don't. In humans and animals, fear is modulated by the process of cognition and learning. Thus, fear is judged as rational or appropriate and irrational or inappropriate. An irrational fear is called a phobia. I like that phrase there, because what does that say? One of my favorite parts of that is, says, fear is a process of cognition and learning. So does that mean you can condition yourself not to be afraid? Do we know that's true? Yeah. Right? And you can you also condition yourself maybe then if we know that pain is linked to fear and fear is linked to pain, does that mean we might have the ability to condition ourselves not to feel pain? Or at least reduce pain? Interesting, Mr. McKeever. I am completely bored at this point. Where the hell are you going with this? Well, we're going to talk about this, then we'll take a break. So how do we quantify fear? Well, we have this thing called the fear avoidance questionnaire that we can give patients. I would challenge that we should give this to all patients. Fear avoidance questionnaire actually tells us what they're avoiding because of their pain. Could that give us a pretty unique insight into all patients if we know that? Sure, absolutely could. There's a Tampa scale of kinesiophobia. Kinesiophobia, what would that translate into? Kinesiophobia. Fear of moving. Yeah, right? You can also use standard off-the-shelf instruments like the LEFS, the LBDQ, the Oswestry. All of those kind of help us as well. You can ask them, cognitive-based interviewing. Tell me about a time where your low back pain made you afraid of doing something. But why would we want to quantify this patient's fear? Well, think about it. Can we address it if we don't quantify it? Can we really address fear without first knowing it's there? No, right? It's just like anything else, right? Let's use the Texas electrical grid problem that we had this past week. If we didn't know that problem was there, then yeah, the problem that happened would be something that we couldn't have predicted and we couldn't have addressed. But 10 years ago, does anyone know what happened in Texas? Guess what happened in Texas? Exactly 10 years to the day of this freeze. The exact same thing. So that just tells us we didn't what? If the same thing happens over and over again, it's because we didn't what? We didn't prepare. We didn't learn. Or we didn't learn from our mistakes, whether that's administratively, whatever you want to go with it, but we just didn't learn from our mistakes, right? Emily and Kelly, do you teach that to your kids? Right? They make a mistake, they should learn from it. I'm hoping you do. Right? Try. Yeah, exactly. It doesn't always get through their kids. Let's face it. I'm a giant kid. I understand that I don't always learn from my mistakes. Trust me, there are still times that I'm doing stuff, working on a car, and I just like go, huh, I've got 7 screws left over. This happened the last time I did this. Didn't learn. Right? Takes a few times, sure does, right? But we definitely could learn from our mistakes. Well, if we can learn from our mistakes, we can also learn from fear. All right, so let's take a pause here. So let me pause recording because I can tell we're starting to melt down a little bit in my brains. So I'm going to pause recording, resume recording. All right, so we are back from break. So last thing we were talking about was quantifying fear and talking about why it may be important to quantify fear. Well, this little flow sheet here kind of talks a little bit about a patient that's got an injury, right? So patient gets an injury. They end up in this vicious cycle, right? So they start with an injury. And once they get that injury, they have a pain experience. So let's think about some pain experiences you guys may have had. Picking up something that's too heavy and you lift it with your back and not your legs. That gives you a pain experience, right? You're like, oh, that's kind of sucked. Okay. Well, we have 2 different routes to go at this point. We can go this route or this route. Most patients go the inside route and they'll catastrophize it. Oh my God, pain, it's so bad. It's just getting worse. And so then they develop this fear of pain, right? So again, picking up an object. So now they develop this fear of picking anything up because if they pick anything up, their back's going to hurt, right? Because they perceive a threat. They get a defensive motivation for it, and they're aware or aroused by that, not aroused that way, but aroused by the fact that every time they pick something up, their back hurts. So now, because every time I pick something up, my back hurts, I do fear avoidance. I don't do it, right? Well, because I don't do it, I end up with some disuse atrophy, right? So my body kind of breaks down. May end up into some disability and definitely some depression, right? Oh, I can't pick up my grandchildren anymore because every time I pick up my grandchild, my back hurts, right? So now, because they have this disuse and this disability, now something else comes along and they get an injury. So they have a pain experience. So they catastrophize it. So they get this fear of pain. So they get a fear of avoidance. And they end up back up here in this disuse atrophy. Do you see this vicious cycle? And overall, as they keep going, what's happening is they're closing the circle, right? Things are just getting worse and worse. And you could almost say that they are going down the what? Going down the drain. Right? Because they're just keeping going in this kind of vicious circle and they just don't get better. And they don't understand why they're not getting better. Well, why they're not getting better is because they keep getting sucked in this vicious cycle. What we want to try to do is give them this exit route to lower their fear. If we can lower their fear about pain, they can confront that pain. If they can confront that pain, they can recover. In reality, looking at this, although we're talking about pain here, this isn't much different than anything else we do in psychology. This is what we do about patients that have fear of heights, patients that have fear of domestic abuse, patients that have whatever, right? We give them the power to confront their problem, right? If we can get them that power, they can get better, they can recover. So it's an interesting thought process that we don't really go into, and a lot of times we kind of skip this process. So this is kind of looking at it a little bit differently here, right? So when I look at this, I think of this like a kid, Okay, so let's take we've got I don't know, 5-year-old kid. Okay, 5-year-old kid falls down the stairs. Bang. And mom and dad are standing there. What do mom and dad do? Kid like time down the stairs. Panic, freak out. Oh my God. They run over to the kid. What's the kid start doing immediately? Crying, right? Develops a pain experience, right? I'm just using a kid here as an example because it's a great example. Now they have a pain catastrophe because now mom's, oh my God, my little baby, I'm so sorry that that happened to you. So now they get afraid of stairs, right? Because to them, the stairs equal falling, equal parents being upset. So now I'm going to be afraid of it. So they avoid stairs. Harder to get them to use it. Greater chance of them getting injured when they encounter it, right? Now let's change that. 5-year-old kid falls down the stairs and there's no parents there to see it. What probably happens? As long as the stairs are carpeted and don't get any major injuries. No broken bones. Shakes it off, gets up, goes away. And later, mom and dad's looking at him. He's got this big bruise on his shoulder or something like that. And he's like, and they're like, how did you happen? Kid's like, probably when I fell down the stairs. You fell down what? Right? Did any of you parents ever have that? The kid's like, yeah, I fell out of a tree or something. You're like, just like, wait, what? Yeah, it just shakes it off, right? They don't have that fear we have. We lost that at some point. As I'm not sure when, but we lose that as adults for sure. We lose that ability to have no fear, right? And it's not just a slogan on a lifted truck. We just lose that ability to have no fear. We lose the ability to confront it, right? So that kid falls down the stairs. There's no parents there. There's no one to tell him that that was a bad thing. So they get no fear of it. And they're like, oh, okay, well, that wasn't too bad. Ouch, look, I've got a bruise. Yeah, whatever. They move on. And they'll go right back up that set of stairs like it was nothing. Same thing can happen to adults. We just end up in this kind of vicious cycle here, right? So this is kind of looking at the interpersonal model, right? This is actually what I just talked about, right? This is looking at that from a pain child-related situation. This is talking about pediatric pain. So you can see how easy it is for a parent to actually catastrophize, there we go, I can speak, pain and lead to child-based pain fear. Now, does that mean we should teach kids that falling downstairs is okay? No. Right? That doesn't, I'm not saying that kids are indestructible because kids aren't indestructible. But compared to adults, kids are pretty indestructible, right? Kelly goes down those same set of stairs and falls. She's probably going to have a bad day. Just saying, it's not exactly the funnest things to fall down a flight of stairs, right? But a kid does it. A kid may just get up from it and bounce and go get on the horse again and play, right? It's the old, leading the horse there, it's kind of an old phrase of, you know, what happens if you get bucked off a horse? What's the first thing you should do? Get right back on. Yeah, we had that in you know, when I started learning to ride motorcycles, one of the things they told me about that is you're going to go down on the motorcycle. You are going to get in an accident where your bike lays down. The minute that bike lays down, the most important thing you can do is pick that bike back up and get on it, even if you just sit on it. Because a lot of people that don't do that never get on a motorcycle again. Same thing with the horse, right? You get kicked off the horse and don't get back on, there's a chance you'll never get back on that horse because you've catastrophized that. In your head, you're like, every time I get on a horse, it's going to kick me off. I have a little bit of that with a horse, but it's not from getting kicked off. When I went to Costa Rica, I went on a horse ride and I got on the first horse. And when I got on the horse, it looked back at me. It looked at their guide. It looked back at me and it just stood there. It didn't matter how much he pulled it or how much I spurred it along. It didn't move. It was like, what are you putting on my back? So I got off that horse and got another one. And this next horse did the exact same thing with me. Then I started to think, man, I gotta lose some weight if these horses are that worried about me, right? Because the horse wouldn't even move. And they're like, well, we're gonna put you on this one over here, but this one's a little kind of wild and he's a little animated. And I'm like, I don't care if he walks at this point, it makes me feel better, right? Put me on this other horse. The other horse was a little bit more, he kind of nipped back at me a couple times, but guess what? He walked. Okay, so it wasn't all horses. It was just these two over here that were jerks. I could have just never gotten a horse again. I would have been actually fine with that. No, it wasn't exactly the best experience in the whole wide world, but I could have been fine with that. So here's that kind of circle, right? And it's patient. When we get a patient, they're just driving around this circle over and over and over and over again. And eventually they start to lose hope. If you're in recovery, completely out of their mindset. They're just stuck in this vicious circle. So this catastrophizing that they do, right? As the Merriam-Webster dictionary says, to imagine the worst possible outcome of an action or event, think about a situation or event as being a catastrophe or having a potentially catastrophic outcome. Whatever. The good thing chat doesn't get recorded. Right, so the catastrophize means we're looking at a catastrophic outcome. Dr. Google says to view or talk about an event as worse than it actually is. In psychology, we have a term called catastrophic or cognitive distortion, right? It's an exaggerated or rational thought pattern involved around the onset and perpetuation of psychopathological states, especially those that are more influenced by psychosocial factors such as depression and anxiety. So cognitive distortion, where we see things a little differently than they actually are. Does that define a lot of our patients? A lot of our patients see their condition differently than it actually is. Yeah, they do. Sometimes we even see it differently than it is. We have to be aware of just this cognitive distortion as well. So how do we look at pain in society? Well, back in I want to say it was the 90s, but it probably was a little bit in the 80s too. We made pain the fifth vital sign, right? All of you do that now, right? When you're talking to your patient, on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain in the world and I have to take you to the hospital, where would you say your pain level is right now? Okay, great. So your pain level is a 10. Now the patient's like, what, great? No, it's not great. It sucks. Oh, okay. Well, where's that pain at? Can you point to it for me? Okay. And can you describe that pain to me? Is there anything that makes the pain better? Or is there anything that makes the pain worse? What we've done is we've created this mindset that pain is bad. And that we should not be in pain. And if you're in pain, you're broken. Right? I'm going to talk a little bit about myself at this point, just because it really kind of relates to this topic. I talked about this before, but I have two fractures I've had two fractures in my neck, right? C4, the last one was C456. And then the first one that I had was C2. And for those that don't know, C2 is called hangman's fracture, because usually it's what happens when you get hung. Your dens snaps off. Well, my dens snapped in a car accident. Most of the times it either leads to paralysis or death. Those are the two options. Luckily, it didn't happen to me, right? But because of both of those, I have chronic migraine. And when I say chronic migraine, every single day of my life, like right now, I have a migraine. It's obnoxious. It's annoying. It's painful. But I'm working. Why? Because let me ask you something, and I'll be 100%, this is not there's no BS. From my standpoint, most days I operate at about 6 or 7 out of 10. If you were to rate it on a scale, There are some days where it's 10 out of 10 and it completely knocks me out. Right? But for the most part, 6 and 7 out of 10. Let's put it on the average American population. What are they doing? If the average American population has that same pain, same headache, what are they doing? Nothing. I could do that. Popping pills. Yeah. Popping bottles and popping pills. Sounds like a plan. Right? Could it be that I might have been through a training about this type of stuff before that's taught me a little bit about my pain? Because I encountered a little bit of a different physical therapist than normal? I did. Right? Pain doesn't necessarily mean you're broken. Right? We all have pain. I mean, sometimes it can, right? If you break your ankle, obviously, then pain indicates you broke your ankle. I mean, just saying. Pain doesn't mean you're broken as a person, right? There's all kinds of theories that all pain must be gone before engaging in normal ADLs, IADLs, or even movement. If that was my case, I'd do nothing. I'd be in bed. Feed me. No. Passive treatment is the way to go. Pain pills solve it all. Yeah, I've had pain pills before. I don't like the way they make me feel. Do they relieve the pain? No, relieve it, but they definitely mask it. For sure. Does that mean I don't take Tylenol? No, sure. I take a Tylenol every now and then. I take Advil every now and then, but I have to have it to function. Right? No matter what you do, you don't ever get rid of your pain. If you don't get rid of your pain, it'll get worse. Maybe. Work and living a normal life will increase your pain. Probably. But that's okay. My instructor had 2 different phrases for pain back when I was in the martial arts. One of his phrases for pain, and sticks with me to this day, is pain is the body's way of thanking you for using it. And then, of course, you have the old classic, you have the old classic Marine one of pain is weakness leaving the body. Right? I'm sure you've heard both of those at some point in your life, right? So we have these idioms, but we don't use them. It's interesting. So we talked about Purdue Pharmaceutical before, and I'm just going to touch on it again at about 1,000th level on this. The early 90s, Purdue Pharmaceutical heavily marketed an opioid-based pain reliever, which had previously only been used on chronic long-term cancer pain. They presented the research position showing how opioids were no more addictive than someone taking Tylenol or aspirin. Non-cancer pain increases. 1997, they had 670,000 prescriptions written. 2002, 6.2 million prescriptions written for oxycodone. In 2012, that went up to 259 million prescriptions. Is that a little bit of money? Going from, 670,000 prescriptions to 250 million, that's lots of money, right? Interestingly enough, cancer pain, the prescriptions only went up by a factor of 4. So the final number, the 259 million, which is interesting, it equates out to enough for almost every American to have a bottle of pain pills, including kids. Right? There are 320 million people in the United States. So 259 million, almost all of us can have a bottle of pain pills. Yeah, it's crazy, right? I love that. My favorite. I don't know why I put that in there, including kids. Whee! Purdue stated that the addiction rate was even moderate to heavy use of opioids in a non-cancer patient was less than 1%. Recent studies indicate that the risk of addiction can be as high as 50% from taking a single pill. Think about that for a second. You take one pain pill, you have 50-50 shot of becoming addicted. Does that terrify anyone else? Yeah, right? Good grief. In 2007, they were charged in federal court by a young district attorney by the name of James Comey. I think we've heard of him before, haven't we? I don't know where I've heard of him before. And Purdue, along with 3 other company executives, pled guilty to criminal charges of misbranding opioids and were ordered to pay the fines of $634 million for the entire 1996-2006 time period. In 1996, just 1 year, their gross sales were $44 million. In 2001, 2002, the numbers ballooned to $3 billion. That's with a B, billion. So that's 634 million. Yeah, so Dylan says many patients would just deal with the pain because they don't want a chance to become addicted. Right. And those are the patients that I'm actually kind of happy for a little bit because they understand the risks. But think about this for a second. So for a 4 or 10-year period, they were fined $634 million. And just in 1 year, they made $3 billion. Does 634 million mean anything to them? That's like us getting a $25 parking fine. Well, that still affects us, right? But I'm just saying, this is literally like insane, right? It's nothing to them. They're just like, okay, this is how we treated pain rather than actually treat it, we medicated it. Ironically, it's the same mistake we made after the Civil War with opium and poppy dens, right? This is crazy. When you actually read the history of this stuff, we have actually done this time and time again, every time. So Civil War happened, right? Did we have a lot of people injured in the Civil War? Yeah, right? So we had all these people injured in the Civil War that had these horrific amputations, all kinds of injuries. So how do we treat them? We created opium and poppy dens for them to relieve their pain. What happens when you take opium and poppy? You become, guess what? Addicted. Okay. So then we get to World War I and World War II. Why were World War I, and this is, again, historical, not necessarily dealing with this, but why were World War I and World War II more deadly than the Civil War as far as human costs? What had changed about warfare? Yeah, technology. Let's just face it, technology changed, right? We went from a musket that you could fire, you know, some of the, okay, there were some Gatling guns in the Civil War that could fire rapid fire rounds, but most of the part, Civil War were cannons, you know, single shot muskets, stuff like that. And most of the battling ended up being bayonet style. You know, we're not even to drones yet. I'm just talking going to World War I and World War II right now. What was the major invention in World War I that changed warfare as we know it? The tank. Why did the tank change warfare as we know it? It was impervious to normal bullets. Right? And the shells it was releasing were a lot more potent than somebody with even with an M1 carbine, right? Okay, so we got a tank. Well, then we've got to escalate because if we've got tanks and they've got to have tanks. Well, if they've got tanks and we've got tanks, now we've got to have bombs so that they get bombed, right? And we escalated. So after World War I and World War II, we needed something to relieve pain for these people that were injured in the war and actually during the war. So what do we use to relieve pain in World War I and World War II? Does anyone know? Because we got away from opium. Opium bad. What did we come up with? Anyone know? This is the kind of the history of pain meds. Heroin. That sound familiar? Oh, it's like, oh. Right, we used to treat people in the war with heroin. It's not opium. It's not opium. It's been processed. Right, there's a little chance for addiction. Guess what do we think we found out after World War I and World War II? People became what? Yeah, got a bunch of heroin addicts. Exactly. Right, okay. So now we go through the Korean War. And we don't want to make that same mistake again. Right? The Korean War and then into the Vietnam era as well. We don't want to make that same mistake again because we don't want to get a bunch of heroin addicts. So along comes pharmaceutical company and says, I've got this great product over here. It's called Vicodin. Or it's called oxycodone. Non-addictive. Guess what? Same cycle, different name. And then we get through the Gulf War and stuff like that, and then we come up with OxyContin. Not addictive, same cycle, different name. But we've had this just repetitive, right? And one thing we haven't done over time is learn from it. When somebody comes along and says something's not addictive, what should be the first thing we think? It's addictive, right? If I said that, like, you know, Cinnamon Toast Crunch is not addictive, some of you would argue with me. Or that Taco Bell or McDonald's is not addictive. We know that it partially is. Yeah, even in the house, right? He did try heroin, right? And why is that? Well, because heroin is a pure, technically, if you get it right, heroin is purer than oxycodone and stuff like that. And there's all kinds, that's beside the point. But just think about that for a second. Opium to heroin to pain pills, early pain pills to OxyContin. We just, same record, just keep flipping it, don't we? It's like the bear went over the mountain over and over and over again. So we need to look at pain a little differently. And we need to look at pain as a respective to a traffic light, okay? Understand and know what to watch for. Green light means keep going. Yellow light means we need to monitor the pain. Red light means what you're doing isn't working and you need to change your approach. If we look at it from that perspective, we can really change the way we treat pain, right? So what would you consider a green light or green flag indicating treatment is working? Pain's getting better, right? But does pain have to get better if function improves? No, right? If the patient's like, you know, my pain's not a lot better, but man, I could walk 2 miles today. That's a victory, isn't it? Take a victory lap. That's a green light. They're improving their social cognitive function. Maybe they're getting out more and doing more things with friends. They're less focused on the pain and more focused on the after pain effect, right? Their family is seeing a change in them, right? I love to hear that from my patients when, you know, they're like, man, I'm not seeing a lot of difference in the pain. And you look over at the significant other in the corner and what are they doing? It's working, right? That's such a great feeling because maybe the person doesn't see it quite yet, but everyone else is seeing things change. Okay. All right. So green flags mean go. That means we keep going the right way. Yellow flags are yellow lights, right? Fear of increased pain, depression, irritability, and stress. All these emotions can cause it, right? So your patient comes in and they're crying. And they're not crying because of their problem, but they're crying because, I don't know, Ben & Jerry's was out of Cherry Garcia today. And that is just a catastrophe. Is the rest of their pain going to be up? Yeah, it is. We know that negative emotions tend to compound other emotions, right? So what happens when we get these? Well, patients want to go on bed rest or extended bed rest, right? They don't want to do anything. Leads to poor compliance or no compliance at all with therapy. And they usually have extreme or exaggerated pain ratings. I love this one. What's your pain level today? On a scale of 0 to 10, 0 being no pain and 10 being the most pain in the world, I got to take you to the hospital. It's a 10, but I have a high pain tolerance. Anyone ever hear that? Yeah, right? And what are they usually doing when they say that they're at a 10 out of 10? What do they look like? They're sitting there cool as a cucumber. Does that mean they are not in 10 out of 10 pain? maybe, right? When I think 10 out of 10 pain, remember that video I showed you guys of the comedian that talked about 10 out of 10 pain? When I think 10 out of 10 pain, I think often of the person writhing around on the floor and screaming in agony, right? That's what I think of 10 out of 10 pain. Or the mother giving birth, right? I was in on the birth of one of my godchildren, which is more than I ever need to see of a friend again. But at the same time, man, I saw the pain she went through to give birth to my godchild. And I looked at that pain at that given moment and said, if men had to give birth, the human species would die out. Just like there's just a scientific fact. I'm just saying it. The species would die out. Right? But I'm going to give you another example. So when I went in with my broken neck from the hospital, I was ambulatory, meaning I could walk around. Right? I was in one of the hard collars. They put me in that at least. That's fine, Michelle. You know, I recorded, so you're good. Thank you for showing up. I was ambulatory. Believe it or not, I drove from my hospital to the Concentra building to get my neck checked out because you had to go to Concentra before you go to the hospital, even though I worked in a hospital. Anyway, drove to the Concentra. They did an x-ray on my neck and said, oh yeah, you've got fractures in your spine. They put a seat collar on me and they looked at me and said, do you think you can drive back to the hospital? What do you think I probably said? Yep. Got in my truck and drove back to the hospital. Get to the ER or the emergency department. They get triaged. The nurse takes a look at my Concentra order and she's like looking at me. And she says, well, what's your pain level right now? I said, well, I mean, for normal people, they're going to be writhing around in about 10 out of 10 pain. I said, it's bad. Like it's probably an 8. And there was a nursing assistant there that literally looks at me and goes, yeah, right. I'm not joking, just that sarcastic. If you're an 8 out of 10 pain, you can't just be sitting there like that. What did she do? That was wrong. Rude, first of all, yeah. She judged, belittled. Could that have caused my pain to get worse? It didn't, but it could have. Could have made me question my pain too, right? And the nurse sticks the blood pressure cuff on me and my blood pressure was like 200 over 160 or something stupid like that. I don't remember, it wasn't that high, but it was bad. And then the old nurse was like, there, that's showing you pain. Because my blood pressure was literally through the roof. So it doesn't necessarily mean, so don't always think, so I know we joke about that 10 out of 10 pain kind of joke patient. Don't always discount it because some people actually do have a high tolerance of pain. And so we got to pay a little bit of attention to that. But most patients, they say they got high tolerance of pain. It's one of those you're like, okay, thanks, Bob. Excessive reliance on all forms of pain assistance. This is the patient that says, I slept with my hot pack on my back. Do you ever have any of those patients? Right, you tell them to use the cold pack or the hot pack for 10 minutes on or 20 minutes on, 20 minutes off. And they just like put the hot pack on. It's one of the electrical ones you plug into the wall and they just leave it on. Right? Sleep changes, disturbances or lack thereof can be problems here, right? Self-medication. So doc tells them they need to take one of these oxycodone every 4 hours and they're taking them every 2. They're going to alcohol. Why does alcohol relieve pain? For some people, what does it do to them? Numbs them. Yeah, right. That's all it is. It doesn't relieve pain, it just numbs you. And some of you know that, right? Because let's face it, we're having bad relationship problems. One of the first things we turn to is alcohol, right? There's all kinds of things that recreational drugs as well, right? And this can be something as simple as marijuana. Right. And I say simple because I'm probably one of the few people that you will ever encounter that'll tell you marijuana is not a gateway drug. Right? Marijuana does not lead to you going to other drugs. From all my experience with my friends, marijuana leads to carpentry and building things out of glass. and seeing what else they can turn into a bong. Marijuana doesn't necessarily lead to other drugs. Could it? Sure. If you got an addictive personality, anything could, Tylenol can lead you to cocaine if you took enough of it. Increase of smoking or the start of smoking. Yeah, right? Yeah, I normally smoke 2 to 3 cigarettes a day, but today I smoked the whole pack. That's a problem. Those are some yellow flags we got to pay attention to. And then we get to our red flags, right? Overprotective or underprotection. Oh, I got some more yellow flags here. I'm sorry. Some family flags, right? You have a parent that's dealing with a child that's in pain. They're really overprotective. Spouse is overprotective. Punitive responses. My dad had a favorite phrase when I was growing up about pain. His phrase was, "Oh, you think you know pain? I'll show you pain if you don't shut up about it." That was a punitive response, right? Or the other famous one was, "Oh, you're crying? Do you want me to give you something to cry about?" Anyone ever hear that phrase before? Right? And then the family just they start disassociating with their family eventually, right? Other work flags, manual work, past work history, changes in work history are common yellow flags for pain. Belief that work is actually harmful, especially manual work. Well, the work's causing me my problems. They're unhappy at work. I would say that most of us, honestly, at some point or another in our lives, have been unhappy with our jobs. Would you agree? Yeah, right? I mean, I can't say that even being a PTA all my life has been a bed of roses. It's not. It's been far better than any other career I've ever had in my life, but it's not a bed of roses. Sometimes it burns you out. Literally, especially if you're working with burn patients. Low educational background. This is interesting. They actually did a study on this. Patients that are in chronic pain typically have less than a college degree. Most patients that have chronic, again, I'm using most because I don't have the study here to quote it on, but most of the patients that suffer from chronic pain have less than a college degree. Well, why do you think that is? Yeah, it's a good question, Sakan. Why do you think that is? No insurance. Okay, good. There's one thought, right? So they're not going to the doctor to get their pain checked out, right? So it just compounds, right? They injure their low back. They're not going to go to the doctor. They don't have insurance to get checked out. So then their low back's injured. So now they're bent over. Now they injure their shoulder. Now their shoulder's injured, right? They don't have insurance. Good. Also, if you've got less than a high school diploma, what's your job perspectives look like? Yeah, hard labored work, right? It's not necessarily the easiest work in the world, right? Even working in a kitchen, not the easiest work in the world. Definitely not the easiest work in the world. I've worked in a kitchen before. Now, are there some jobs that you can get into? Can't afford to take time off? Good. Yep. All this leads to that, right? Multiple jobs, right? If you have less than a college degree, typically you work more than one job. I think the average is now 1.5. But I'm going to go back to not my family, but back to the generation before me, because a lot of y'all are younger than me. Even those of you that think that you're about the same age as me are still younger than me. I'm looking at you, Emily. You're not anywhere close to me. I just look so awesome for my age. That's all it is. Going back a generation. So going back to the generation that grew up in the 40s, 50s, and 60s. And let's not talk, we're not talking social. Please don't. That's a totally different being. If they didn't have a college education, could they survive? Could they raise a family? Could they? So we're talking 50s, 60s. Did you have to have? Yeah, back then you could. Of course, back then a house was $4,000. Right? There's an itch out to find a picture from one of my districts back home in Pennsylvania. They have a picture of this house in Harrisburg, Pennsylvania, which is in the Harrisburg School District. And in 1994, that house was $44,000. Now it's a small little one rancher type house. And back then, a teacher's salary was $62,000. They did a comparison to now. That same house, which is still in that same area, is $436,000, and a starting teacher salary is $51,000. Says something about our economy a little bit. But yeah, it's just kind of interesting. So nowadays, in order to have an easier job, you typically, and I'm not going to say easy because I'm going to say my job may be easy on my body, but it's definitely not an easy job. You guys are not an easy group. No, just kidding. I'm joking. I am joking. It's not easy to teach. It isn't. But yeah, so typically shift workers and usually have negative work experiences with pain. I just watched a special, and do any of you guys watch Last Week Tonight with John Oliver? Do any of you watch that on HBO? Okay, I love him. I don't really totally want to ruin last night's episode if you haven't watched it, but last night's episode was on the meatpacking industry. And it talked about an interesting thing where if you report workers' comp problems on the meatpacking line, you get fired. That would be a reason for them to have a negative experience with pain, wouldn't it? If I report my pain, I get fired. If I lose my thumb and report that I lost my thumb, I get fired. Better just stick a glove over it. Interesting thought. Compensation flags. There's a lack of financial incentive to return to work, or they make more while they're not currently employed. It is, oh yeah, watch, please do me a favor, Kelly. It's up on YouTube. Watch the whole little skit. You don't have to watch the whole show, but it is up on YouTube. It just got put up last night. Watch the whole thing on it because it talks about why it is illegal, but it's not enforced. It's actually really interesting. Mainly because OSHA itself is so chronically underfunded and understaffed, they'll never get caught. But yeah, it's kind of crazy. This is an interesting thing because I hear this a lot. And this is a misnomer. I put this in here because it's a talking point, but I don't like this phrase here. The patient has a lack of financial incentive to return to work or make money while not currently employed, because this is something we heard over COVID, isn't it? Well, if we give them more money on unemployment, they won't want to go back to work. Did anyone hear that? No one heard it? I heard it a lot, mainly because I'm into the politics of it. You know, or the big argument right now, and it's been an argument for a while, and Andrew Yang was one of the big proponents of it, was universal basic income. Doesn't matter who you are in the United States, you should get this flat check every day, every month or whatever, to help cover daycare costs, health insurance costs, blah, 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 stuff like that. But if we provide people with universal basic income, they're not going to want to work. You know what they found in other countries that have universal basic income? They have a higher employment rate. Just saying. Just leaving it out there. Extended time off work due to previous lack of time off work. They don't have the ability to do it. History of repeated workers' comp complaints, right? Previous history, similar conditions. Talk of consistent legal action. I love these patients. Do you think I should sue? I don't know. Is sue your friend? Right? I think I'm going to sue my work. That's when you got to get worried. If you ever hear that in the clinic, you need to let your PT know. Because anytime patients threatening legal action against their work for something, they can equally threaten against you. Can you give me more time off work? I'm not quite ready to return. Did any of you go to a PI clinic? Personal injury clinic? I can't remember if we sent anyone to Lions this time or not. Do you went to Lions, didn't you, Jaira? Yep. Yeah, I know John. John's a great guy. And actually the whole clinic is really great, right? What was it like working with some of those PI clients? Give us some insight. They weren't all bad. I know that, but did you encounter some of these that are like, can you give me some extra time off? Yeah, for the most part. Well, that's because he also runs a pretty tight ship, doesn't he? I'll give that to John. Man, he runs, Mr. Lyons, he runs a tight ship at his clinic. That they're going to do what they're supposed to do. So it's one of the good things I'll say, right? Oh yeah, let's milk this attorney lien. right? But did you encounter any of the patients that were worried about that if they kept going to physical therapy, they'll get less money? Right, and there's the opposite. Kelly's got the exact opposite, right? Firemen that was just wanted to get back to work, and probably they shouldn't yet. That happens in the military too, up at the VA, right? I just want to get back to my platoon. And you're like, dude, you can't yet. You can't even walk. But I got to get back. They're suffering without me, blah, 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 blah. Same thing happens in those jobs. It's interesting, right? But this is the fun one. I love to watch, and I'll do this occasionally. I'll leave the patients alone for a little bit or walk away for a little bit to see if they talk together. Because that can tell you some things, right? They talk to the patients to validate, oh my God, yeah, I've got this back pain. Oh, I see you've got that total knee replacement. Man, they talked about me getting a total knee replacement, and that must suck. Does it suck? You ever had that in the clinic where the patients are literally feeding on their own pain, right? And it's usually, I'm not to judge, but it's usually the little old people that are doing it because they tend to talk a little bit more than people like me that I don't want to talk to anybody, right? But it's funny to watch because that really gets you kind of into their mindset a little bit. Medical diagnosis flags. Looking for medical sanctioning of the disability. Do you think I can get disability for this? I lost my pinky. Do you get disability for this? Seeking multiple diagnoses and possible diagnoses conflict with another. My case is special. I'm different than every other car accident. Well, you are. Don't get me wrong. Every single car accident, even, Erica's car accident is different than every other car accident that happened. It just is. It's not necessarily that you're special. It just means it's different. Passive treatments. Oh, I just want modalities today. Or can I just get I don't have time to do my therapy today. Can I just get traction? Anyone hear that? I love those. Those are my favorite ones. Yeah, Hector hears that all the time. Yeah. Soft tissue would be nice today. Yeah. And when you hear that, sometimes what you have to do is you have to make sure you schedule that. You may have to tell them, okay, well, Tuesday or Monday and Friday are going to be your hardcore therapy days. And then on Wednesday, we're going to schedule for primarily manual therapy and soft tissue. There's two reasons for that. Number one, it keeps them from whining about getting soft tissue the other 2 days. A little bit, not often. But the other reason is it gives them something to look forward to. They know that on Wednesday, it's going to be a little bit easier of a treatment, maybe, unless I'm the one stretching you, then it's not easy. But they just know that that's kind of their day that, okay, this is the make me feel good day, right? Continually seeks out provider until diagnosis is validated. This happens a lot. You get the patient. I love when you get the patient's medical chart and it's like Dr. So-and-so, Dr. So-and-so, Dr. So-and-so, Dr. So-and-so, Dr. So-and-so, Dr. So-and-so, Dr. You're just like, good Lord, that is all the orthopedic surgeons in the area. Looking for quick fixes of the problem. I was watching last night on television and Dr. Ho came on and he was talking about this magical back brace that he sells. Did anyone have any patients kind of like that? Or I was reading, I was reading about glucosamine chondroitin, or I was reading about this, or I was reading about apple cider vinegar was a big one a few years ago. Right? Repeated mention of lack of fixes from the previous provider. The last guy didn't fix me. You're not going to fix me. How many visits do you think I could get for this condition? That's a personal injury question a lot. That's literally, it means that how long do I have to go back to work? So if this hurts, should I stop doing it? No. And they stare at you like, again, you're a three-headed alien from Jupiter. No, if it hurts, it's just your body telling you that it hurts. Doesn't mean you should stop doing stuff. And we got the red lights. Why would you consider red flags? Well, patient pain increases drastically, but proportionate to the condition, right? So you're stretching a patient's sciatic out and you're doing some nerve flossing, but the pain really spikes when you're flossing that nerve. That means you're doing too much, right? You're stretching a patient out and their pain spikes. It means you're probably doing a little too much, being a little too mean. You're being a little too like Mr. McKeever. Patient pain migrates down a predictable pain pattern, dermatome or myotome. Continually getting worse from the social societal world. Patient begins discussing what would happen if you got litigation against you. Oh, I've had this conversation before. So have you ever been sued before? What? I've had one. Does your clinic require you to carry malpractice insurance? Do you have malpractice insurance? What would you guys do if you get that question? Can it make you freak out a little bit? What do you think? They're fishing for money, right? Yeah, you're going, oh, this isn't good. Those are the times where I give them something simple to do. Like, okay, I'm going to put you on hot pack for 5 minutes and guess where I'm heading to? I'm going right over to Dr. Reskin and being like, hey, I need to talk to you about this next patient in the office real quick. Can you come with me? And all of us need to be on the same page watching for stuff. How do I go about filing complaint or compliment? You aware of this one too with your state board regarding clinicians. I want to give you a compliment to the state board. Do you think that really means they want to give you a compliment? Nope. And just remember one of the things. If they put a comment on your state board license, how long is it there for? Ever. Yep. Now, there are ways that you can go about legally getting it removed and stuff like that. But again, a lot of times in the healthcare field, we are guilty until proven innocent. So just be aware of that. Is there anything else that a patient said to you guys that were red flags while you're out in the clinic? Yeah, see, I showed you the website shows them all. Yeah. If you look on mine, I've got a delayed payment of my yearly renewal. So, I mean, I've got a bad one on there too, because I was in the hospital with a broken neck. Is there anything else a patient's ever said that has raised a red flag? Can you think of anything that's something different here? Any of you heard anything different from a patient that made those hackles in the back of your neck stand up? No? Okay. Just curious if anyone had anything fun to add to that list. So pain is a malfunctioning of cognitive processing. Pain is a malfunction of cognitive processing. That literally says your pain is where? Brain. It is. Pain suffers a painful experience, becomes afraid of the painful experience, poorly understands how to resolve the painful experience, worries about further damage, suffers another painful experience. In that cycle, and down the drain they go, right? So modern thought of pain, simplify it down. Pain is a multiple system output activated by the brain based on a perceived threat, whether that pain is real or not. They did an interesting study, and I have to see if I can find the study. I was reading about it, where they blindfolded a patient and told them what they're going to touch is painful. So be ready for it. And they made them put their hands on ice, and guess what the patients encountered? Pain. So there's something about if that threat is real or not, right? Epidemiological data shows that chronic, widespread, nonspecific musculoskeletal pain is on the rise. Yeah, but I would challenge this a little bit. So it's saying that chronic, widespread musculoskeletal pain is going up. I would also challenge that we're better at diagnosing that as well, wouldn't you think? We're a little bit better at diagnosing musculoskeletal pain versus other things nowadays. And then maybe you're seeing better treatments for it than we used to. When I grew up, and even I'm thinking back to like my dad and my mom, musculoskeletal pain wasn't something you went to the doc for. It was suck it up, buttercup. Right? Especially in chronic low back pain. Some studies indicate chronic pain prevalence may be as high as 35% in patients visiting a healthcare provider. Americans account for 5% of the world's population. So think about this. This is really an interesting fact. We count for 5% of the population, but consume 80% of the global opioid supply. And 99% of the hydrocodone supply, so the Vicodin supply. House was right. Just like let that, I mean, I'm not trying to judge here, but just let that sink in a little bit. We have 5% of the world population, but consume 80% of the pain pills. Is anyone else just flabbergasted by that? Like, does that, so to me, that just, when I saw that stat, it just blew my mind. Maybe it's just me, but it just really, like, especially the 99% of hydrocodone, right? Which is Vicodin. We consume 99% of the world's Vicodin supply. That means 1% goes to the rest of the world. And I am not thinking that the rest of the world is in less pain than us. So that means we have to treat the brain as well as the body. And this is the phrase I get when I start talking about this stuff. But Mr. McKeever, I want to be a therapist. I don't want to be a psychologist. Too bad. Our worlds are intermingling now. It's one of the reasons I got my degree in psych. On top of the fact that I wanted to figure out what was wrong with me and my family, mainly my family. But we are gone, and we will have this, there will be PTs that have this debate on whether PTAs are actually therapists. I am not one of those that get offended if a PTA calls himself a therapist. I know many PTs don't get upset with PTAs calling themselves therapists because they are a therapist is one who provides therapy. You're not saying you're a physical therapist. You're just saying you're a therapist. Just is what it is. But be aware that some PTs do get offended by that, that you are not a therapist, you are a therapist assistant. Just be aware of that. I'm just putting that out there. If you're writing any type of case study, don't call yourself a therapist. Just saying that. So we've thought of it PT, right? The main reason of pain is a stiff joint. Main reason pain is tight muscle. It's altered incorrect muscle recruitment, trauma, wounds. Could be a flawed view. Could just be the pain is in the brain. So what if the pain and disability is due to a faulty brain functioning? So here we have, my name is Edith. My pain is due to chronic bulging low discs at L3, L4, L5, L6, and L7. I have bulging discs because I have arthritis and degenerative joint disease, which has caused me to get degenerative disc disease. Now I think I might have fibromyalgia stuff or maybe lupus. I mean, I had a weird rash on my face the past couple of weeks when I wake up. My pain meds aren't working any longer. I only take them when I need them. But there are stronger ones that are there stronger ones you can get from me? I read and I shouldn't do any exercise until all my pain is gone because the body's telling you to stop until you don't have it anymore. Maybe I just have this rare blood disorder I read about. Does that sound like a patient? Anyone ever encounter a patient like that, that literally you just sit down with them and all of a sudden it's verbal diarrhea? Yeah, like a lot of you are saying, yeah, that's, yeah. So I look at this, right? Because I've got friends, oh, wait till you guys become PTAs. Because guess who's going to start coming to you? Oh, your family and friends. They may even be starting to do that now. Can you give me a massage? I'm not a massage therapist. Right? So all your family and friends are going to come to you. And this is going to be something you may hear from them. When I hear this, and I'm looking at this, and I've got Edith here, and she's in my clinic. I'm looking at that no one has explained to her what her problem really is. So what's she doing to find out what her problem is? Where is she going to get help? Yeah, Dr. Google, right? She's going to Dr. Google. And, you know, there's this link at some point she's going through it. And there was this link to this rare blood disorder that causes low back pain. And well, it's on the internet, so it must be true, right? I'm just saying. So is it a flaw in our education? Physical therapy approach all diagnoses on a prevailing biomedical model, focusing on tissue and tissue injury. This is true. Think about what you've learned so far, or what you think that you haven't learned so far through your program. That most of what we deal with is musculoskeletal injuries, right? Orthopedic professions commonly use anatomy, physiology, and pathophysiology to explain this to a patient. And that, tell me if you've ever heard this or visualize this when I talk about it. So if you look at this little model of the knee I have here, these brown structures are your ligaments. This white material is your meniscus. The red beefy looking, well, that's your muscle. You have a microscopic tear, we think, of your medial meniscus, which is impinging and not allowing the knee to move freely through its range of motion. So you show them in the little model. And this piece is catching here when you experience pain. Can all of you visualize that? I can. I can visualize a PT or PTA saying exactly this. They've got their little model of the knee, right? Or, you know, and they're going through it and they're like, see, this is what's happening to you. Right? Does that sound familiar a little bit? Do we do that as PTA instructors too sometimes? Have I like ever brought over a model and been like, so this is this? Yeah, we do. Because we're kind of based in neuromuscular kind of recovery. It's just interesting. And studies have shown there's limited efficacy in decreasing pain or disability by looking solely at the biomechanical model. Right? In fact, studies have indicated that purely biomechanical approaches may increase fear in patients, which may increase pain and further increase fear avoidance. So what kind of science literature do we keep around the clinic that could further reinforce this problem? Well, let's think about it. Do any of your clinics you've been to have like the pain models on the wall? Or like pictures of what a rotator cuff tear looks like? Yeah, right? And so they're walking and seeing that stuff, right? There's not a picture of a cat holding on. It's like hang in there on the walls. We got pictures of body models all around, right? One study actually indicated that almost half of people with a bulging shifted disc displayed no symptoms of low back pain. So the disc may actually absorb some shifted weight, right? When would pain start occurring? Well, if it started moving around. Interestingly enough, the study found out pain started occurring when they were told they had a bulging disc. Could you see that happening? Right? Maybe they go in for some other type of condition. I don't know. They're going in because they're getting an ultrasound of the stomach or something. And through that ultrasound, we can see they've got a bulging disc. And we bring, did you know you have a bulging disc? That's not really realistic, but kind of idea here. We've shown that sometimes that's enough to cause them pain, even though they've had it for years. Study done by Tate, Levy, Noel, etc. Patients who underwent microdiscectomy and were shown the bad material after surgery recovered significantly better that were not shown the material. Leg pain, 91.5% versus 80%. Back pain, 86 versus 75. Limb weakness improvement, 90% versus 56%. Paresthesia, numbness, 88% versus 61%. Reduced pain medication. Look at this. Reduced pain medication, 92% versus 69%. Just by taking a little jar and going, see, this is what we cut out. I don't know, that just, I don't know, maybe it's just me, but that just boggles my mind, right? So this is interesting here. This is looking at low back pain and development of arthritis, right? So this low back pain is this blue curve and the development of arthritis. As arthritis gets worse, sometimes what we find is low back pain goes down. Correlation does not equal causation here, though. Because through the 40s and 30s, 40s, and 50s, you're also working more, aren't you? Whereas hopefully by the time you get to 60 and 65, you're starting to think about what? Hopefully retirement, right? I'm probably going to work till I'm like 90. It's interesting. So looked at rotator, this one looks at rotator cuff injuries. 1/3 of the people over 30 have an abnormal finding on their MRI. 2/3 of the people over 70 have an abnormal findings. So if we took the class right now, we've got 25 students, 26 students, whatever it is, and we put all of us through an MRI, right? And let's add Dr. Reskin, Dr. O'Neill, and Dr. Sokill in, so we have a nice 30 people, right? If we have 30 people and we send all of us through an MRI for the shoulder, 10 of us will have abnormal findings in our rotator cuff. Yeah, not saying much, but I'm pretty sure that if I'm looking at Dylan, I'm looking at AJ a little bit on that. They probably got some abnormal findings in the rotator cuff. Dylan's like 100%. Yeah, right? But 60% of those people reporting pain are under 45. And then after a successful rotator cuff repair, 90% of the people have further abnormal findings on an MRI. Right? So they've shown that outpatient physical therapy may be far more beneficial for rotator cuff surgery or rotator cuff tears than surgery. In my anecdotal evidence, anecdotal meaning what I've encountered, I don't have that research to back it up. Most of my patients that I've seen with rotator cuff repairs are worse coming out of surgery than if they never had surgery. Now, there are a few of those that rotator cuff was pretty shredded and it has helped them. But I've seen a lot of rotator cuff repairs that they come out worse. They come out with frozen shoulder. They come out with limited range of motion. They never get internal rotation back. Whereas we, came out worse, exactly, right? So you just think about that. So does that benefit our field? Sure, it benefits our field. Does that mean we want to tell them, hey, surgery may not be an option? I don't usually do that. I usually let the PT do that. We got to be careful. We got to walk that line, though, because we tell too many of those patients that, surgeons will stop sending us stuff. But it's just interesting to me that even though, most of the people with rotator cuff problems are over 70, most of us that are complaining about it are under 45. It's interesting to me. All right, so let's take a break here because I'm going to get into a situation here we're going to talk about. Where's my little cursor? There it is. So pause recording. So we're going to come back from break here. Is anyone's brain kind of getting fried yet? Are you seeing where I'm going with this a little bit at least, or maybe having kind of a visual where we're going? Or do I have you completely lost? What are you guys thinking so far? Are you learning some interesting facts? Kind of give you some insight into pain? If you're not, it's okay. I'm just curious. I know I'm a geek about this. Like pain neuroscience really, really, to me, is like total nerdy, and I love it. All right, so let's look at a situation. You're here in Vegas, walking down the street singing do-a-diddy-dum-diddy-do, right? You misjudge the edge of a curb and your right foot slips off the curb. You completely invert your foot to the point of a complete stretch of the lateral compartment. Ouchie, sprain. And initially you get that shock of mainly pain, seeing it happen. Oh my God. I'm sure all of you right now, or those of you with weak ankles, are actually feeling this in your ankle. As you do this, you see a guy coming craning at you in his Mustang, not paying attention at like 50 miles an hour. What's going to happen here? So you're kind of hanging off the curb. You twisted your ankle. Now you see a Mustang coming right at you, 50 miles an hour. What happens to the pain? You roll, tuck and roll. If you can dodge a car, you can dodge. Yeah, you bounce right back up, no pain, gone. That pain is history. Why? Why? What caused that? Is the injury still there? The injury's still there, right? Why is the pain gone? Yeah, fight or flight is kicked in, right? Your brain has said, yes, that is painful, but dying is worse, right? So it shuts off those pain receptors. And instantly, you're able to get back up onto the curb, or you get across the curb, or like Erica says, tuck and roll, right? So that means that pain is a decision of the brain based on a perception of a threat. And this can be demonstrated in stuff like the military, because I've known military members who have had their entire both bottom of their legs blown off and are still shooting at the enemy. Because at that point, if they don't shoot at the enemy, what's probably going to happen? They're going to die. Yeah. Right? So think about that for a second. They've got both their lower limbs blown off. And hopefully they're lucky and the explosion was hot enough to cauterize the wounds. Maybe not. Maybe they're bleeding out while this is happening. Right? But they're able to continue fighting. Like, that doesn't say something about the brain. I don't know what does. It amazes me. I don't know. It's just kind of one of those things you're like, wow, that. And the person, true, yeah. Don't get me wrong. It does say not everyone would do that, right, Kelly? Some people would just freeze. I don't know. It's interesting, right? And you read stories about this specifically. I'm just using moms as an example. Doesn't mean dads can't be this way as well. But there have been numerous stories of, mamas where their child's in danger and they may be injured or hurt or worse, and all of a sudden they're able to do things that are just super heroic. Because that instinct kicks in that pain is not important right now. And, there's been a couple stories where, maybe the kid gets stuck under something and mom somehow finds the adrenaline and strength to lift the whatever it is off their kid, even though despite it's tearing every muscle in their body and causing them heart stress. And now normally the normal human being, that's going to be extremely painful, but for whatever reason, the mom can ignore that pain, the child gets out of danger, and the mom falls over dead. It's just, and I'm not saying that dads can't do that either. It's just always stories about moms when we're related to this. I think sometimes they think that us guys just sit around and sit on the, the lazy boy, but whatever. Just an interesting thought process. I don't know. The pain is a brain's perception of a threat, right? So that means pain is in the brain, plain and simple. It's a multi-system output activated by an individual specific pain neural signature. This means pain, again, is a learned experience. A neural signal is activated when the brain perceives a threat. So if the pain doesn't exist, does that mean the injury doesn't exist? No, the injury's still there, right? You get shot and don't feel the pain, right? Because maybe the shot burned off your nerve endings. Doesn't mean that the injury is not there. Just mean the brain goes, okay, that's not important right now. What's more important is I'm going to bleed out to death. Right? It's kind of interesting when you think about that. So when the brain perceives a threat, the first thing the brain does is, how dangerous is this threat? And I'm really getting self-conscious because I feel like I've got a bald spot forming on the side of my head. I just want to let you guys know that. The shave tomorrow. I keep turning my head and going, So how is the threat dangerous, right? So if the threat is dangerous, provide more information, and then we make an initiation of the pain response. If the threat is not dangerous, well, maybe we can get inhibition of the pain response. So is this lecture painful yet? Are you getting, Kelly's like, yes, I'm getting some negative response from this, right? So now that we realize that pain is a lot more complex than we once thought, we can know that pain equals injury and injuries equal pain, but we can have pain without injuries and injuries without pain. So that means the brain is in pain. And this lecture right now, to see you guys that are feeling pain, this lecture is a perceived threat. That's why you're experiencing pain from it, right? And it may be a perceived threat in a couple of different ways, right? This could be a perceived threat that, oh my God, I don't know enough about pain. Could also just be that this is challenging, right? That's okay. Could this also be a challenge of norms that's making you feel uncomfortable? Yeah, could. Right? When I first started learning this stuff, I'm like, oh crap, pain is not all in the brain. It's caused by the pain chemical receptors, substance P, and it's actually at the location of pain and blah, 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 blah. Well, guess where that substance P has to come from? So emerging research shows that explaining to patients their pain experience from a biological, physiological, and psychological perspective of how nervous system, the brain's process to allow patients to move better, exercise better, think differently about the pain, and push through the pain. So spending some one-on-one time with your patient on something other than pure physical therapy and more on pain education can go a long way. So like this research is now leaning towards, if we talk a little bit about the pain to our patients, they get better. So why don't we talk more about pain? What do you think some of the reasons we don't talk about pain is? It's not reimbursed. Wouldn't you agree? You don't get reimbursed for talking to a patient. You're not a psychologist. You're not a psychoanalyst. You don't get to, so we don't do this a lot. We may have to lose a unit of pay in order to teach them about their pain. Oh my gosh. So this pain neuroscience education talks about adjunctive therapy, right? Manual therapy, including mobilizations and manipulations. Really good for these patients. Soft tissue treatment, massage. You'll be amazed. And I mean, I know that, what was I going to say? Oh my God, my brain is now just got melted down there. I know Tyler can tell us about this, because I think Tyler's our only LMT in here. I can't remember if somebody else is. I apologize. I just know Tyler is. That can tell you that sometimes just a simple massage, even the easiest massage in the world, relieves a ton of pain. Just does for patients. And then sometimes the strongest, most deep tissue, most exhausting massage for the massage therapist standpoint does nothing for them. Yeah, it's just that human touch. Neural tissue mobilization, so flossing nerves, spinal stabilization, home exercise programs, circuit and aerobic training, right? And then no adjunctive therapy at all has been shown to actually improve their pain, meaning no physical therapy only, just pain neuroscience education. What? So not even doing anything is shown to relieve their pain? What? Right? So we talk about, when we're talking about this PNE, it's just pain neuroscience education. I just abbreviate it because that's a lot of stuff to speak out, right? Talks about the neurophysiology of pain. Talk to them a little bit about how a pain signal gets sent. Now, don't go into depths about the the A deltas and the B beta fibers, and that's a little too far in depth, right? But just talk to them about how the pain cycle happens, right? It's a sensory response that goes back and maybe can trigger a motor response. Stop referencing anatomical biological models all the time. Does that mean you don't teach them about their knee? No, teach them about their knee, but you don't need to bring the model out every time. So this is your knee again. Can you show me where your meniscus? No, don't do that. Right? We don't discuss emotional behavioral aspects of pain. We should, right? Talk about nociception and nociceptive pathways, how the brain works. I've gotten into the habit of just talking to them simply about the gate control theory and using the old bumping your head theory, right? You bump your head, you rub it, you don't feel the pain. Sometimes just that can help them understand, oh, well, that's weird, right? And they may get an idea that pain is in the brain. The basics of neuron and neuronal pathways, including fiber types, can be useful for educated patients, but maybe not for every patient. Talk about inhibition models. Talk about that like I said, the gate control theory. Talk about the opiate control theory, and then talk about the plasticity of the nervous system. Let them know that the brain can heal itself if we allow it to heal itself. So these are two terms that are becoming more and more common. Have any of you heard these terms while you're out in your clinic, either peripheral sensitization or central sensitization? Okay. The reason I'm bringing these up, these are becoming more and more common board questions. So I wanted to distill this down to a simple paragraph so you understand it. And you probably still won't fully understand it, but at least if you have a paragraph, you can reference it when you're getting questions on it. So peripheral sensitization is an increased sensitivity to an afferent nerve stimuli. This occurs after there's been an injury or cell damage to the area, produces a flare response due to nociceptors producing a lot of neuropeptides, which results in an increased sensitivity to heat and touch stimuli, which is referred as primary hyperalgesia or primary hyperaldynia, meaning hyper pain syndrome, if the stimulus was not a painful one prior to the injury. For example, a gentle stroke to the skin where before the injury is not painful, but after it is interpreted as pain. So when we get peripheral sensitization, the patient has had a traumatic experience of some sorts. And again, could this traumatic experience be psychological? Yeah, absolutely. It could be psychological. But because they have had this traumatic experience, they now are experiencing exaggerated peripheral pain, typically to pain non-producing items like touch, like heat, like cold. So they experience an exaggerated or hyperaldynia or allodynia response where the pain shoots up even though you're just maybe giving them a massage. Is that a problem? Is that going to make our therapy difficult? If every time we touch them, they're screaming? Yeah. Right? So that, what are we going to have to do? Because I know Dr. Ovreskin talked a little bit about this in her hand lecture. If we have peripheral sensitization, we are going to have to do what to it? Desensitize. Good, Anthony, right? Yeah, good, Sakana. Right, so we're going to have to take that hyperpathic ways that's causing them pain just by touch and desensitize it. Maybe we have to change our touch. You know, this happens sometimes where maybe you're a little too deep on your soft tissue mobilizations, you know, a little too much petrissage, not enough effleurage. So you may have to back down some. You may have to use things like cotton or cloth to put a barrier between you and the patient. It's weird that some of the stuff happens. Now, remember, this is not a normal response. So this is an abnormal response to a normal finding. Central sensitization is a little different. This is nociception that is described as the neural process of encoding noxious stimuli. Central sensitization is an increased responsiveness of nociceptors in the CNS to either normal or subthreshold afferent input, resulting in hypersensitivity, responsiveness to non-noxious stimuli, and an increased pain response by stimuli outside the area. So the main difference between peripheral sensitization and central sensitization is where that problem is occurring. In the periphery, it's the localized nerve center, peripheral sensitization. It's the localized nerve endings out there that are causing this hyperpathia, right? In central sensitization, what's causing the hyperreaction? Central, it says it right in it. Yeah, the CNS, the brain and the spinal cord, right? Which of those is going to be harder for us to treat? Peripheral or central sensitization? What do you think? Just, yeah, central. Yeah, it is. Right? Think about it. If it's a problem with the brain, it's going to be harder to treat than something of just rubbing and kind of getting the skin used to being touched again. Right? That can be really problematic. But if you look, they look very similar, don't they? Both the conditions look, they're both an exaggerated response to pain. So could we be treating a patient for central sensitization and it could be peripheral sensitization? Yeah, good. Right? That's one of those cases where maybe all of a sudden with touch, it's getting better. This may have been peripheral, not central. Or maybe we think it's peripheral and we're treating it as that and they're not getting any better. And now we know it's central sensitization. So this is very much like we talked about when we were back in vestibular, right? Because we talked about if it's peripheral, we treat it. If it's central, we habituate it. You remember I said that before? So if it's peripheral, we're going to treat it. We're going to try to get rid of it, right? We're going to try to normalize it. If it's central, we may have to get them used to that new normal. You know, I know this isn't something you want to hear, but this may be your new normal. So looking at what we discussed, well, how do we alter a patient's way they receive pain and perceived and alter their pain experience, right? So patient experiences an event and they go to a medical professional. They go to a medical doctor, they get prescribed medication. They go to a surgeon, they get prescribed surgery. They go to a chiropractor, they get prescribed bone cracking. And depending upon the type, maybe use less useful treatments. Maybe some apple cider vinegar, who knows what they're prescribing. They go to a traditional physical therapist, they get prescribed physical therapy. Makes sense. Go to a naturopathic practitioner. I have no idea what they're going to do for them, but I always thought that ND stood for not a doctor. And they go to a psychologist or psychiatrist, and they get told it's in your head. In reality, that may be the most correct answer. Now, if you tell a patient their pain is all in their head, is that going to throw up some defenses? Yeah. But it is technically the right answer, right? They get a little, so don't shy away from it, but also don't be like, this is all your imagination. Right? We're living in imagination land. No. So body to the brain to the body, right? What if instead of looking at those biomechanical reasons, we continue to treat them and then in conjunction, treat them from the top down, brain to the body, right? We could break the pain cycle. We could alter their perception of pain. We could theoretically alter their life entirely. And I'm really speaking to this from a personal perspective as well, because I'm going to use I use myself as this example of this, because man, when my migraines got as bad as they were, I was legitimately thinking, that's it, I'm done, I'm never going to work again. Right? Just lock me in a dark room and leave me in there to become Smeagol. Because that's pretty much the way I felt, right? Just by getting a little bit of PNE, it changed the way I looked at things. It drastically looked at things. Could also alter the way we practice, because we may look at it going, this kind of works. So how do we use PNE in the clinic? Well, clinic's got to be step-by-step untreated. And again, please understand, by me talking about this does not make you a pain neuroscience specialist. What I am giving you here is like a 2-week course distilled down into like 3 hours. Kind of like what I did with vestibular, right? But the reason I'm giving this is becoming a lot more mainstream than it used to be, right? Do a lot of reading, right? Reading is fundamental, especially in research, right? Application in the clinic is directly proportional to the education we receive. Application in the clinic is directly proportional to the education we receive. We know this. If you go for a clinic, a continuing education on a certain topic, you come back and treat people with that same thing every time you go. Just the way it is. It's the way we're built. We want to use our new knowledge, right? It's noticeable when people go to those CCU courses, right? If you go to a course on blood flow restriction, every patient that comes in, you're going to want to do blood flow restriction on for a little while, just because it's a new fancy toy you've got. Pain neuroscience education is only one phase of helping the patient. Just because we help them with understanding that it's in their brain, if we don't fix the problem from a physical therapy standpoint, it still is not going to be completely fixed, right? We need to change their behavior, and they have to be open to that change. The clinic also that you work at has to be open to this change. Jerry, I'm going to use you as an example because I know that Dr. Lyons is actually getting a little bit more into pain neuroscience. And so could you see this making some drastic changes if you applied this entirely on some of those personal injury cases? Or maybe, yeah, right? But is it going to lose out a little bit of money? Maybe. But we might get better results out of it, right? Looking for further clinical application protocols, just starting down this path is only the beginning, right? When I started down this path and I started learning about pain neuroscience education, it really kind of fed me. I was really interested in this stuff and learning how it works because, again, I was coming at it from not only, there is PT that has a lot of neuro, Yeah, and I reference some of their stuff in this. Well, not reference it, but I talked to them and kind of honed some of my lecture based upon that. But when I started going down this line, it was from two different perspectives. It was one from a PTA perspective, because I wanted to learn how this new idea kind of worked with patients. The other thing was from a personal perspective. How could this PNE education or PN education help me with my personal problems, my personal pain? Right? So traditional interview and evaluation, patient comes in, what brings you to therapy? Where's your pain? Can you describe your pain? Can you point to where your pain is? Can you describe your pain to me? Is pain consistent or intermittent? What makes it better? What makes it worse? What do you want to get out of your therapy? Those are traditional eval questions. They are. Change the game up. What do you think's going on with your condition? What do you think we should be doing, or what should be done for your condition? Why do you think you still hurt? What would it take for you to get better? Where do you see yourself in 3 years with regards to your condition? What gives you hope? What is your expectation of me? Not what are your goals? What do you want me to do? You could have a magic wand and remove your pain right now. What things that you've stopped would you do again? Is that a more, personal kind of thought process? Yeah. How would you feel if you got some of these questions, even if you didn't have all of these? But all of us have had physical therapy at some point, or most of us have. If you got some of these questions in the eval, would that have made you feel a little bit more personal? Yeah, they actually care about me. Yeah. Especially the one I really like is, what do you expect of me as a clinician? Could that maybe help some of those patients that are getting worried about you as a student, if you ask them that? Right? What do you expect of me as a clinician? What are you worried about with me? Okay, great. Let me show you that I will take care of you. Give me the ability to show you value in my treatment. If you give me that, I'm willing to do everything I can for you. Oh, they care about me. Well, this is weird. Are you angry at anyone about your condition? Let's explore that. Tell me a little bit about it. Has anyone made you feel like you're just faking it or telling you it's all in your head? Even though in the reality, what are we telling them? It's all in their head, right? Not this negative way, but in reality way. Does your work lay guilt on you for your condition? Or, right? If you could do anything tomorrow without pain, what would it be? You know what's funny is, I've actually asked this question before. Do you know what one of the number one answers I get for that is? It's kind of amusing, and it's something I've never expected them to say. Have sex. Like, that strikes me, because that tells you what's stopping them from actually having sex. Their pain. Huh. I don't know. It's interesting that I've gotten that over and over again. It's not just been one person that said that. I've gotten a couple people. They're like, I've even had some little ladies that are like, I have some raucous sex, youngin. Oh my God, that's kind of scary. The approach is more low tech, but listening therapy, and you may be the first person to actually listen to the patient. Nothing is above a strictly personal therapist only question. You're making no assessments. You're just being a detective. Yeah, Kylie's heard that, right? It is. You're being a detective here. I've talked much about following the crumbs, following those breadcrumbs, right? We're looking at it. Has anyone explained to you, so starting the pain talk, to change their method and thought process, has anyone explained to you why you're hurting? What do you think the number one answer I get from that is? No. Well, they told me that it's because of this disc in my neck. Hold on. Let's not even talk about those mechanical stuff, right? Would you like to know why your pain isn't getting better? Okay, think about that loaded question right there. It's loaded in a couple ways. Because number one, that's the way the patient feels, right? Isn't it? But it also tells them that you may have the secret to getting their pain better. Now you've got them like a little fish on a hook, right? Before we start physical treatment, would you like me to discuss how pain works and possibly expand your knowledge on pain? And can we possibly explain why it's so easy for you to suffer in pain? Sure. Oh man, I'm looking at this stuff going, man, if I remember back when I tore my ACL and my PCL, my LCL, all my L's in my knee. I didn't have any of this stuff. I had no idea why I was in pain. I thought I was in pain because I tore everything. Well, partially. But man, this stuff could have been interesting to me. You know, action potentials. Can we talk about this? Absolutely, right? We've talked about the membrane potential being minus 70, the firing potential being minus 50, right? And what happens? So think about that. So we've got that minus 70 resting potential. We've got that 50 or minus 50 firing potential. But do you remember what happens when we constantly get those graded potentials from back in anatomy? What happens to that firing potential? It moves up. Wait a minute. Think about that. If I'm constantly getting these low graded simulations of pain, and this is my get better level, that get better level is going to get harder and harder, isn't it? Huh. So you're saying that action potentials can help explain pain? Sure. And then how long does it take for that to get back to normal again? So after starting PNE, right? After we do it, we've got to do something physical. Again, we cannot just do PNE. Now, there are some clinics that are opening, and I will tell you this. I know of one, at least in Pennsylvania, I don't know of any here, that are opening that are pure pain neuroscience physical therapy clinics. And they may be strictly cash pay. They may, some insurances are starting to pay a little bit more for this because they know in the long run, it's going to be cheaper than patients getting surgery and stuff like that, right? But we have to do something physical. We still have to justify as being physical therapy. We're not psychologists. We're just not. So we've got to do some exercise. We've got to do some movement. Breathing and relaxation is huge. Teaching them how to deal with their pain. And then we have to send them home with some homework. We have to send them home with something to think and read about, even if it's just a small pamphlet on pain neuroscience. Get them into a walking program. They're saying, oh, I don't want to move. Tell you what, let's start out this week on you just walking out to your mailbox every day and walking back. Is that starting a walking program? Yeah. Right? 2 to 3 basic exercises, no more. I've said that I think I've said that since we started, right? You don't want to give them a gobble of exercises, right? You just want to give them a couple that they can do that are easy. And then goals to be set every week, right? Okay, so next week we're going to see if we can get a couple degrees in range of motion. Next week we're going to see if we can get you walking twice a day out to the mailbox and back. Set these achievable goals so that helps. So looking back at pain, just kind of from the end point here, pain is normal. Pain's there to protect us, but it can also hurt us. And if we change the way we see pain, it will help. And patients themselves are truly interested in their pain. They want to know about it. Patients can only take on modern pain science, meaning we got to help them, lead them down the way. So we got to turn down that body's alarm system therapeutically by doing PNE, by doing aerobic exercise, by doing manual therapy, pacing them, graded re-exposure to the problem that caused them. If they injured their ankle on the stairs, we got to give them graded exposure to doing the stairs again. Let them show their ankle's not going to get necessarily hurt there again. And then breathing and relaxation techniques. I've talked through this, but understand that pain neuroscience education is not purely hands-off like others think. I've talked through this, and I've been through a couple of programs where the PTs and PTAs that are in the program look at the instructor and they're like, this is bull crap. That's putting it nicely, right? I don't have time to do that talk therapy. I don't know why we always default to rednecky voice when I think of clinics like that. But it is to be used in conjunction with other therapy, right? Just like if you went and you did get training on McKenzie technique, McKenzie's not your only tool in your toolbox. This is just an extra tool. And we know that the more tools we have, the better we can treat a patient, right? The more we listen to a patient, the more the patient will provide us with the breadcrumbs we need to help them. Also, we know that if we're talking to a patient during therapy, what are they doing? That's kind of important. If we can talk to them the whole time they're in therapy, they're breathing. Right? So we know that we can use that, right? Education by itself is limited, right? There has to be follow through and the patient has to want to follow through. Is this going to fix the patient that doesn't want to get better? Because we've all encountered those patients, or maybe you haven't, but you will eventually in your career. Is this going to fix that person that just doesn't want to get better? That they are, it may, but typically not, because they don't want to get better. We can't, yeah, this is the old, like, I can drag a horse to water, but I can't force that horse to drink. Right? Education on diet is just as important as the rest of therapy. Right? We know for a fact, right? We know for a fact at this point, or let me rephrase that. Do we know for a fact that there are foods that kick up inflammation in the body? Yeah, sure we do, right? And do we know those foods vary based upon the person? Right? Just telling somebody to eat blueberries because they're anti-inflammatory may not work for that person, because now you've given them blueberries, but the side effect is they already had an ulcerative colitis, and now you're making them poop every 5 minutes. And you kicked up their ulcerative colitis. So we have to pay attention. So again, diet doesn't fit everybody, but keeping a weekly food diary does help. Do we know that excessive caffeine consumption can cause problems? Yeah. Right? To the point that we become numb to the caffeine effect. It's just like any other drug, right? There are also some studies that show that maybe excessive caffeine consumption actually kicks up inflammation. And then there are also some studies that show excessive caffeine consumption kicks down inflammation. So it just shows that people are different, right? I know that people laugh at me because I can drink soda and coffee up until bedtime and still just go right to bed. Like nothing ever happened. Whereas, I maybe give some of you guys a cup of my coffee at, 10 o'clock at night and you'll be up all night. Just the way we're conditioned. Reintegration of their normal social functions is equally as important. We need to get them back to doing stuff they want to do. So what do you have to lose by trying it? Nothing. Hold your patients, be there for them, show them, tell them, do them. Have them do. That came out wrong. Right? No, I didn't get any laugh on that. Come on. That was kind of funny. Now you guys are dead at this point. Thanks. Provide regular and consistent feedback, but change your feedback techniques. Right? Do you guys ever notice that I do that? That I don't always give you feedback in the same method? Have any of you ever noticed that? Or that sometimes I'll call you out and sometimes I won't call you out on stuff? Yeah. There's a reason for that. Sometimes some of it's just to keep you awake. But some of it I learned that maybe and I've had this before where I've given feedback directly one-on-one to somebody and has made them really uncomfortable. Whereas if I give feedback to their partner that I'm really applying to them, they absorb it. Change feedback cycle a little bit. Right? Maybe do it more at the beginning or maybe do it more at the end. Change it around a little bit. Discuss new sensations and relate them back to PNA, right? So, oh, well, now my back's starting to feel better, but man, my knees are starting to hurt. Okay, let's explore that. Why is that happening? Every session, ask them about their HEP, not just their exercise though. And this is something I really think is important is I think journals are really important. I think they're underused. I keep a journal for myself every day. My blood pressure, my heart rate, my pain level, stuff like that, just because it helps me kind of track things as I go along. I'm not saying you have to get that psychotically in depth, but keeping a journal can be a really good thing. I like to journal some of my psychological conditions, also some of my pain conditions. And it really lets me go back and go, oh man, yeah, you know what? Today sucked, but it wasn't as bad as last week. But ask about their HEP. So talk to them about their exercises. Integrate their HEP into their ADLs. Make them appropriate to what they do. If you've got a soccer player, make some of their HEP kicking a ball. Right? You've got a mom that knits, make some of their HEP knitting. Find a way to do it. More likely to get them to do it if you make it relevant to them. So these are kind of the P&E pearls that I've picked up over the years, right? You have to be smarter than your patient. Most times we are, sometimes we aren't. Education should be paced, just like any activity. Right now, I have fried you because I put basically 2 weeks worth of knowledge into your head in one day. If I could have paced this out, I would have taught this lesson over about 4 days. But we don't have that luxury right now. You guys are an accelerated program. I got to get this stuff into you as quick as possible, right? Again, looking at this, all I can do is plant the seed. All you can do with your patient is plant the seed, right? Plant the seed, water it a little bit, see if it sprouts. If it doesn't sprout, what could you do? Plant some more seeds, right? I learned that growing up on the farm. If the corn doesn't grow, there's a couple of reasons why the corn doesn't grow, but maybe you just didn't put enough seeds down. Don't force it, but look for back doors into it as well. If the patient seems to be opposed to learning a little bit about their pain, okay, see if there's ways you can sneak it into them. Tether all of your treatments together. Make sure they understand there's a clear path between treatments. Set boundaries for you and your patient, because this is important with chronic pain patients. They are probably the ones that show up the least, don't show up to therapy, cancel appointments, stuff like that. But that means you also have to be on time. If you're late to your appointment with your patient, what does that set in the patient's brain? It means they can be late, right? This goes back to the old adage, if you're not 15 minutes early, you're late, right? Don't miss appointments. Do your homework though. If your patient's talking to you about something, go research it. Come back and say, hey, I found this out about it. Your patients are smarter than you think they are, to a point. What's the average education level in Nevada? Does anyone know what the average education level is in Nevada? 7th grade. Yeah, like you thought high school grad sounds pretty good, right? Average education level in Nevada is about 7th grade. I think we're like 47th in the whole country or something like that. That means the average reading level, the average education level in the United States, or in Nevada specifically, is about a 7th grade education. So what happens if you give them a really complicated book to read or pamphlet to read that has, 10-letter words and stuff like that? Not even going to bother. Yep. All pain is real, even if it's in their head. And remember that pain is subjective. They won't even understand it. There's a better term, Kelly, right? They may read it and go, what is this witchcraft? Pain neuro what? The more detailed their homework, the more breadcrumbs you can get. Have them bring their journals. Movement is still the best and biggest painkiller on the planet, right? Motion is lotion. The more they move, the better they'll feel. So eat your movement with every meal. So I put a couple of these books up here, and I cannot stress, I highly recommend all of these books. I have read them all. Some of them, like Why Do I Hurt, is more based from a patient perspective. And it's a really short and quick read. I highly recommend, like, if I could give you guys kind of a pack of books to take with you on your clinical, all 5 of these books would be in that pack. Because these are all 5 books that have changed the way I see pain and changed the way I see the brain, right? So Why Do I Hurt, again, is a patient book about the neuroscience of pain. A lot of pain clinics use this book. They usually hand it out or they loan them out for the patient to read. written at a very kind of, again, 7th grade level, but it really helps explain it. And I highly recommend reading it. Back pain. Guess what? Similar author, right? Adrian Lau, that's now focused on just back pain. World of Hurt is a little bit more complicated. Now we're starting to get into a little bit higher end stuff. And then we get the 2 books on the far right, the Norman Duhigg stuff. I highly recommend both of those because they teach you about the brain. I really, honestly, the book that changed my life by far is this one here, The Brain That Changes Itself. I had a clinical instructor back when, dinosaurs roamed the earth, and this was her graduation gift to me from graduating from the actual, my clinical affiliation. And she said, read this, this will change your life. It changed my life. And I was like, yeah, right. And I read it and I'm like, holy crap. It did change a little bit about the way I think about the brain. All these books, though, highly recommended. I can't stress it enough. If you can pick them up, right? I've read The Brain's Way of Healing about 4 times, just because it's a little bit highbrow, talking about the frontiers of neuroplasticity. So it took me a little bit to get all the concepts in it, but all of those are great books. Can't recommend them enough. Any questions? I know I fried your brains. I'm going to get out of the PowerPoint just so I can have a big picture of me. Any comments? What did you guys think? Give me some feedback. Was it a lot? Quite a bit. Okay, good. A lot of pain. Did it change any of your perspectives? Anyone looking at this going, I'd like to learn more about X, Y, or Z? Okay, it's a lot to think about, right? It's interesting when you give some of this stuff, especially if any of you get to go to the VA and you give some of this to vets. Because I think sometimes our vets have had a lot more experience with pain than they let on. Right? Even if they're not really injured that bad, they've had experiences that none of us will ever understand. Right? It's just the way it is. That's part of service of the country. And I think sometimes giving them stuff like this to read helps them understand that they're not alone. There's a lot of stuff on PTSD out there that is pretty good nowadays. Right? But really, when you think about it, and just tie this back, is PTSD much different than pain? I mean, actually, chronic pain versus PTSD. I mean, they're not that different in the way we could treat them. Like how it's all in the brain, exactly. Yeah, right? That's kind of what I'm getting at, is some of this stuff not only applies to this, but it can apply to other things in life too. Thinking about even working with your kids. I could use some of this on how to educate kids. Does this only apply to adults? Absolutely not. I've used pain neuroscience education on kids as well. I didn't realize it, but coming up through the martial arts, when I look at some of this, my instructor was really using pain neuroscience on me, even though he didn't know what it was. I know he didn't. But some of it was what I was learning in the martial arts. Because there are many times where my instructor would tell me that I've got to work through my pain and I've got to find a way to work through it, because that's what you do as a human being. In reality, that's what he's teaching me, is that pain isn't all just musculoskeletal. Any questions you guys can think about? Or are you guys pretty much fried out? All right, I'm going to stop recording then.